CEO of the Mater Private and the outgoing chairman of the Private Hospitals Association, and I'd like to welcome you to our annual meeting. We have over 300 people registered for the meeting, and you're all very welcome to what has turned out to be a virtual event. But we do have the Minister for Health here in person, and I will introduce Bill Maher, the incoming chairman, who in turn will introduce the Minister. But I think one of my most important functions here this morning is to thank our staff, the staff of the private hospitals who have stood up for the last 18 months in extreme conditions and took care of our patients. So on behalf of the Private Hospitals Association, I would like to thank the staff of the private hospitals for their work over the last 18 months. It is appropriate on a day that is in other jurisdictions, Thanksgiving, to give thanks to our staff, and thank you all. And I thank you both as a hospital operator, but also as a surgeon. I have seen firsthand the work you've done over the last 18 months. You should be very proud of the effort you've made for the hospitals, for the patients, and for the state. So let me introduce Bill Maher, the incoming chairman of the Private Hospitals Association. Bill is the CEO of the Bonds Hospital Group, former CEO of the Celta Group, and is a well-known, I would think to most people online, as a shrewd and astute hospital CEO and group CEO. So I'll ask Bill to take over the Private Hospitals Association, and I'm sure in the challenge that is coming, he will do an excellent job, and I wish him the best of luck. Bill.
ICU, but to address the more systemic challenges within our health system. Whilst we're dealing with coronavirus, and we still are, and I know that's an important message for everyone to hear, this has not gone away, and we're doubling down on all of the public health advice, I would say that perhaps the most significant impact of the pandemic, which saw a very clear focus, and rightly so, on COVID patients, coupled with a significant reduction in capacity, and then if that wasn't bad enough, exacerbated by the recent cyber attack on the HSE, leading to a significant cancellation of non-urgent elective patients, is the worrying increase in waiting list volumes and waiting times. And I know, Minister, that's something very dear to your heart. Whilst public hospitals are making best efforts to reduce waiting lists, and I've worked in many public hospitals, I know the efforts that go into this and the commitment that all staff there give, there is significant work also ongoing in the private hospitals through NTPF and through HSE procurement. Unfortunately, waiting lists continue to climb each month. There are now over 900,000 patients on waiting lists. This is now of profound concern, and unless addressed, will have significant impact on health outcomes. Minister, it is vital that the public and private sectors work together to form a long-term partnership to tackle waiting lists. The PHA today is calling for a major effort to be initiated to address this problem. Much, much more can be done to draw on the capacity of our member hospitals nationwide than is currently the case. I believe government must make a sustained commitment and demonstrate unswerving resolve to bring about a meaningful change to this protracted problem and deliver on the targets set out in Sláintecare and indeed manifesto promises that were made. It is notable from our research that 8 out of 10 people we surveyed indicated their preference for a joint approach to be taken to resolve this long-standing problem. We look forward, Minister, to the promised strategic multi-annual waiting list plan that you're working on. That is something that we've been looking for a number of years, and also the promised ministerial task force to oversee delivery of this plan, and we stand ready once again to assist in the country's time of need. Finally, Minister, it is very important to call out and recognise success. The achievements of your department and your leadership and that of the HSE in respect to the national vaccination programme has been very, very commendable. There is no doubt that we would be in a much worse position today were it not for the record vaccination rates achieved here in Ireland over the past 12 months and the speedy rollout now of the booster campaign. Minister, delegates and guests, thank you for your attention this morning. I'm delighted to invite Minister Donnelly to now address the conference. Thank you.
For fear I give the wrong speech. I could get myself in awful trouble. Good morning, everybody. I was delighted to accept the invitation to speak at the conference this morning. And I know you had intended to gather in person for the event, but given the changed public health advice, the move to a virtual setting is very welcome. I know it's frustrating for people, but I'd like to thank the PHA for showing leadership on this issue. I don't have to tell the people gathered here that the last 21 months have seen unprecedented strain put on our health and social care services. That we as a nation have been able to deal with this pandemic as effectively as we have really is a testament to the dedication of the hundreds of thousands of women and men providing health and social care services in our country every day. And I'd like to acknowledge the very important contribution of the private hospitals and their staff to this national effort. As well as the care that you're providing through your normal models of care, the additional capacity and staff that have been provided have been essential in our response to COVID. The epidemiological situation in Ireland right now is concerning. The continuing high transmission rates and the growing case numbers are having a real impact on society and are continuing to place an unsustainable strain on our health services. Last week, government introduced a number of measures as part of a national response to the latest surge in COVID here. New measures include working from home wherever possible, restrictions on opening hours for bars and restaurants, and household close contacts staying home for 5 days with 3 clear antigen tests. This adds to measures such as the flu vaccine, the winter plan, PCR and antigen testing, intensifying engagement with the private hospitals, and protections for nursing homes. One of the most important tools available to us, of course, is the vaccines. And as everyone here knows, they're incredibly effective. And the mounting evidence on the booster vaccines, both from here and from countries like Israel, the UK, and others, is very, very encouraging indeed. The vaccine programme, as Bill has said, has gone well in Ireland, with one of the highest vaccine take-up rates anywhere in the world. And I'm very pleased to report that good progress is also being made on the booster vaccine campaign. Between third doses for the immunocompromised and booster doses, as of Tuesday, over 630,000 boosters had been administered. The programme for residents in long-term residential care and for those aged 80 and over is now substantially complete. Most of the immunocompromised have either had a booster vaccine or have been offered a booster vaccine. About half of our healthcare workers and half of those in their 70s have now received a booster vaccine, and very relevant for members of the PHA, any healthcare worker can go to any participating pharmacy and get a booster vaccine. There's no need to wait, there's no need to be scheduled. Progress is also being made now for those in their 60s, and the numbers are beginning to accelerate this week as the 5-month gap kicks in greater volumes. One group that I've been very keen to have the booster vaccine made available as quickly as possible is those with underlying conditions. And I was delighted yesterday to be able to put that in place with the HSE such that those with underlying conditions will start being offered the booster from next week. This is cohorts 4 and 7 from the initial booster campaign, and it's very important. Over 80% of our COVID ICU patients have an underlying condition, and for our vaccinated COVID ICU patients, the figure is 98%. 98% of them have underlying conditions. So obviously this group is essential in terms of keeping people safe and in so doing, taking the strain back off our hospital system. There are many reasons for the success of the vaccine program, but one of them is a strong operating model that provides very clear direction from the centre. It ensures the resources are available when they're needed. It trusts local teams to get the job done and make local decisions on the ground. And it collects and analyses performance management information so that we know where we're winning, we know where we need to do more, and then we adapt quickly. I want to see this same operating discipline brought to the waiting lists and to tackling the waiting lists. They were too long before COVID arrived, as we know, and because of COVID, because of the cyber attack, they're an awful lot longer now. We're only going to tackle these waiting lists if we change the way that we approach them. The most recently published NTPF figures show that 75,000 people are now waiting for inpatient or day case procedures. Nearly 650,000 are waiting for an outpatient appointment, and 31,000 are waiting for a GI scope. To this, we can add a large number of adults and children waiting for other diagnostics and other social care, including, for example, children with disabilities waiting for therapeutic treatments in the community. The numbers waiting for an inpatient day case procedure peaked in mid-2017 at about 86,000. The NTPF's commissioning work began to impact on the waiting list from the middle of that year and contributed to a reduction in the total number of patients waiting on the inpatient and day case lists. In 2018, through a collaboration of the HSC, the NTPF and private hospitals, improvements were made in reducing waiting times, with numbers falling to about 70,000 by the end of 2018. That was a reduction of about 18%. During this time, the NTPF paid for treatment for nearly 20,000 patients in private hospitals. Between 2017 and 2020, the NTPF spent nearly €95 million procuring treatment from the private hospitals. Tackling the current waiting lists is a top priority for me and for this government. For this year and next year, I've allocated a waiting list fund of several €100 million per year. On the 7th of October, I published the Acute Waiting List Action Plan. The plan, drawn up by the Department of Health, the HSC and the NTPF, is a measure designed to run until the end of the year. It's a short-term plan. It outlines a series of targeted measures designed to address growth, including a far bigger role for the private providers. In addition, the Department, the HSC and the NTPF are also working on a multi-annual waiting list plan to bring the waiting list time in line with government targets. It's being overseen by a ministerial task force chaired by the Secretary General of my department, and it includes representatives from the HSC, the NTPF, and the plan is going to be informed by lessons learned from the vaccine task force. For 2022, an additional €250 million, comprising €200 million to the HSC and €50 million to the National Treatment Purchase Fund, has been provided in respect of work to reduce hospital and community waiting lists. This will be used to fund additional activity to both public and private sectors. The €50 million additional funding provided to the NTPF brings the total funding to the NTPF for next year to €150 million. That means that the total waiting list fund for next year is €350 million. The increase in the NTPF's budget is a reflection of the importance that I attach to it and by extension to yourselves in tackling this issue. I recognise the contributions that you have made and can make in the time ahead. I've met many of you in recent months and recent weeks and recent months and indeed over the years as we plan our response, and I want to see further engagement between the public and the private sectors as we respond to the waiting lists and providing care to those who are simply waiting too long to get it. I'm aware that improvements can be made in how this work is planned and funded with a longer-term strategic relationship, giving you the opportunity to invest in capacity and to have a much greater impact on the waiting lists and make sure that public patients also get the care they need when they need it. Given the current public waiting lists, we should be using all available capacity that the private sector can provide. We also need this to be deployed to the current winter pressures. Our health and social care services are facing significant challenges this winter, as we all know. In providing emergency care to deal with COVID-19 alongside the normal challenges of the winter period, the system is under an unprecedented level of pressure. And to deal with this, we published a HSE winter plan on the 15th of November, focusing on ED avoidance, patient flow and egress. The plan recognises that a whole system response is required and outlines how the HSE proposes to manage the challenges across primary, community and acute care. It includes measures to allow the public system access private healthcare capacity through various agreements, including the safety net arrangement. In addition, the HSE has a procurement framework in place to provide capacity for urgent time critical care and for elective procedures. Again, the HSE needs to be using all available capacity that private providers can make available. The government allocated an additional €1.2 billion, including winter funding in budget 2021, to support health services across the healthcare sector. This has been maintained in budget 2022 and it's been increased. Significant funding was provided as part of the previous winter plan in budget 21 to allocate additional beds on a permanent basis across the hospital system. Right now, about 800 non-ICU acute beds have been added to the system. An additional 50 are scheduled to open before the end of this year, and about 300 more are funded to be opened next year. The funding has also been used to increase diagnostics and additional home support, and including an additional 5 million home care hours for this year. The ratio of consultants to population in Ireland is low. It's too low. We're committed to increasing these numbers. The government is committed to growing consultant numbers, and over the past 2 years, over 350 additional posts have been filled. We're investing significantly in health services and will continue to do so in order to meet our goal of universal health care. And for the first time, the health service is now funded to increase both infrastructure and staffing to the levels recommended in the health service capacity review. Planning for the 3 new regional elective care centres is being progressed, and a draft business case is currently undergoing evaluation. One area being expanded, of course, is critical care. Before the pandemic, we had just 255 critical beds, which we all know was completely inadequate. 52 million was provided this year to fund an additional 66 permanent beds. 42 of those are now open, bringing our baseline critical care capacity to 297, and more will be open before the end of the year. The HSE has been funded to increase critical care capacity by the end of next year or early into 2023 to 340 beds. Now, when we hit that target, when you compare from the start of the pandemic to this point of 340, it'll be an increase in our critical care capacity of 33% in a very, very short period of time, but we need to go further. So beyond the immediate target, we propose to develop new critical care facilities at 5 prioritised sites: Beaumont, St James's, the Mater, St Vincent's and CUH. A total of 117 additional beds will be added. That'll bring the total permanent base capacity to 446 beds, which exceeds the recommendation put forward in the capacity review. Of course, as we all know, capacity alone isn't enough. If we're to achieve universal health care, we have to modernise. We have to update models of care. We have to update patient pathways. It includes further advances in the deployment of advanced nurse practitioners, for example, which are showing really, really positive signs in terms of new and better ways of working and helping patients. It includes fully utilising the skills of GPs, the skills of pharmacists, the skills of optometrists, the skills of many other healthcare professionals, which right now we're not doing. There's an awful lot more opportunity for our healthcare professionals to work to the fullness of their skill and to their training. We also need serious improvements in e-health and in management information. It also includes much better utilisation of beds, much better utilisation of operating theatres, much better utilisation of diagnostics. We're not using the assets we have well enough, and this needs to change. It also includes a much more strategic relationship with private providers, particularly in tackling COVID, in facing the winter pressures and reducing and ideally eliminating the waiting lists. So in conclusion, I'd like to take the opportunity, Bill, to wish you the very best as chair of the PHA. I'd like to thank John for his leadership over the past 18 months. And I'd like to again acknowledge the incredibly important contribution that you've all made during the pandemic to support the delivery of healthcare during these very trying times, to make sure that patients got the care they needed and to keep people safe. I very much look forward to engaging with you on a regular basis to see how we can face the many challenges in front of us. I believe that universal healthcare is the single most important project of our times. I believe that every man and woman, every girl and boy should be able to access the best quality healthcare when they need it. Everyone I've discussed this with in private practice believes it too. Together, I believe we can make and must make this a reality in our country. Thank you.
I was getting worried about the scale and scope of your introduction for a moment there, Bill, but thank you for the kind words. And just to acknowledge John's work over the last nearly 2 years now on behalf of the PHA and private hospitals. I think the contribution has been very significant, and the Minister has acknowledged that. I think it's been a very difficult time, and the private hospitals have stood up and assisted what was really a national public challenge. What I'm going to do is just go through some of where we are now, the challenges we're facing, and then maybe at the end bring it back to some of the things we've been discussing, which are how do we address the access challenges. I think if I commence by saying I'll cover a few topics, and they are the topics I'll cover. If I start with the epi data, I'll work on the basis, Bill, of 20 minutes, and I'll keep myself to that. So just to say, and I think the Minister has referred to this, we are obviously again in a time of rising COVID, which is concerning for us as a society. I think the booster program and the vaccination program remains extremely important. You can see that while 8.3% of our cases are in the over 65s, 44% of hospitalizations are in those categories. And that just indicates the age and condition related nature of hospital admissions. And indeed, the Minister has referred to ICU, and I'll come back to that in a few moments. And that graph on the right of my screen is just showing you the trend since 29th of February, since the index case in Ireland. And you can see of late, maybe I blow that up a bit, you can see that we're moving back into high caseloads. The hospitalizations associated with the number of cases is lower now, but at the same time we are at high numbers, and concerningly high numbers. So the peak, as you can see in the middle of the graph, was January, February, and that was the Delta variant. That trend is very much matched by the trend in intensive care occupation, and the Minister has addressed the occupancy issue in intensive care. But what you'll see from that slide is that in the major waves of COVID, we've experienced major peaks. So we go back to late January 21, you're looking at over 200 patients in intensive care beds in Ireland for COVID alone. And we also obviously in the public system need that intensive care capacity for other purposes, both deteriorating patients medically and indeed serious elective surgery. And the figures, the latest figure on that graph is 131 COVID occupancy. The point the Minister made about vaccination status and the importance of vaccination, so within ICUs and on the latest data, which is a week back, there are 52% of patients are not vaccinated that are in and admitted to ICU. And indeed, as the Minister indicated, the bulk of the remainder sadly are immunocompromised or have pre-existing serious conditions. So from our point of view, obviously the vaccination and the booster is really important. In terms of just what's happening today or last night in the acute environment, we are seeing around 600 patients in hospitals with COVID. That will include the ICU numbers, but it includes all patients COVID positive in hospitals and the major sites that are affected. While they move a bit, you can see there's a strong Dublin component to that now, but also UHL is Limerick and CUH Cork are high. Mater has 66 patients in at the moment, Beaumont 50. And I think John made the point early on that the health system is all about people providing care for people. And so 66 patients in the Mater is a huge requirement in terms of care burden, isolation, and change in practice. And I think the change in practice in the acute system over the last 2 years has really been quite phenomenal. And it's visible from the front door of the hospital right through the hospital. In terms of our ICU at the moment, last night, we got 131 patients in ICU with COVID. Total number of patients was 308. The Minister's referred to the wider capacity, so I won't pursue that. In terms of the other things we're watching, just for information, things like oxygen utilization, which you'll recall were very much in the media, both internationally and nationally in the commencement of COVID. We're watching the red line at the peak there is back in mid-January, January of this year. And we're still well below that in terms of oxygen consumption, but it's a key thing for us to monitor. We're also monitoring non-invasive ventilation outside of ICU, and that has been on the rise within the system and does increase when we see an increase in COVID presentations. That graph is just showing the upward trend, and it's breaking out between COVID and non-COVID, non-invasive ventilation. And that one is showing the summary of ventilation outside of ICU. So you'll notice to the right-hand side, it's been increasing in recent days and weeks, and at the very latest, just coming back a little bit. So the and the use of hospital capacity for COVID, which has varied following the community instance of COVID, has obviously demanded significant bed capacity, significant staff attention, and has brought a significant additional burden of care. And that data is just giving you some sense that the mean length of stay is 2 weeks. The ICU length of stay can vary from 1 to 65 days. So it's been a major demand and remains a major demand on the provision of public health services. And the private hospitals have played a major role in supporting that and in providing care that would otherwise not have been provided in the public system over the last 18, 24 months. The other thing that we are looking at ourselves is the movement of patients across hospitals. So critical care retrieval services, the graph on the right showing the 2021 data, you'll see that MICAS, the Mobile Intensive Care Ambulance Service, is moving more patients than really ever before across the country, as indeed you'll notice that in terms of pediatric acute transport, the same is happening. So there's very significant, and there are signs both of severe care need, very intense care need, and also service pressure on various sites. There have been occasions, and so we look at January, February of this year, there would have been very high movement of patients across the country to balance the ICU demands. And if I go back, just going back to what's happening in the emergency departments, that graph and the 2020 figure, the one that's dipping down, is showing the trend in the early stages of the pandemic. And you can see in the early stage, there was a significant fall off in attendances in emergency departments, very much associated with fear of the infection and all the measures and attention that were in place in terms of the population at that stage. The red line is the current trend. And so you would hear the HSE articulating that emergency department attendances have increased and are at or above previous levels. That graph is showing you that. And we have seen in some parts of the country, so if I look at Limerick, September 2019 to September 2021, we're up 23% in ED attendances, and admissions, in fact, are up over 20% as well through the emergency department. So very significant pattern change happening, I think, in the background. That's the admissions picture. The admissions 2021 overall are now, having been above, are now level with 2019 levels. And in recent days, we are seeing a slight fall off in attendance at emergency departments. So that's, and I think that is reflective of the public dialogue and public behaviour. So from our point of view then, in terms of working with the private hospitals, the Safety Net 1 arrangement, if we go back as far as the 1st of April to June 2020, the HSE entered into an arrangement whereby, in effect, with support of government, it took on the full cost of the private system for a 3-month period. And that provided a first phase of response to what was then an emerging pandemic, putting huge pressure on the whole system, public and private. And I think it's important to remember, and we'd be very conscious, that the strain that's in the health system is across the whole system, and the staff and the response to the health system is a unified single response. And the pandemic does that to us. If we weren't acting that way, the pandemic would certainly force it. We then entered into Safety Net 2 after that, and that was to support response in the current year to the pandemic as it was playing out in January, February, and right through the year. We hadn't imagined at that stage we'd have a cyber attack in May, and again we have relied on what we would refer to as Safety Net 3 to support the loss of activity in May, June, and really into July as well. And the private system has worked with us on that. All of those arrangements have been agreed with all private hospitals, and really have been hugely supportive of getting us to where we are now. And those arrangements were designed to provide both urgent care and also included diagnostic, surgical and medical beds. And that response has been very significant. We used very significant capacity in terms of Safety Net 2. We're using very significant capacity, we'll go through the numbers, of within the private system. And under both Safety Net 2 and Safety Net 3, as we would refer to them, over 11,000 patients moved under Safety Net 2, and since May, 9,000 patients under Safety Net 3. And in fact, our bed day utilization in the private sector is rising again from around 1,000. It's currently at about 1,500 bed days per week, and it's rising again. So, and we very much welcome that and want to continue that. And the shift is from, we're now looking to move urgent surgery, and are doing that on various sites as the COVID pressures are making such work more difficult on public campuses. And just in terms of bed day utilization, that graph is indicating that anyone who looks through these slides, I'm very happy to make them available. I think in terms of the challenge, sorry for too much data on that slide, but I think the lines are important and really at the heart of what's happened in the pandemic. If I go back to 2019, the waiting list for inpatient and daycare was 66,000 at that stage. It peaked actually at 86,000 if you look at the May 2020 data, and it's back to 74,000. So clearly those, and that's spread over, access to care for over a range of time, but well beyond staunch care targets. So from our point of view, all of our focus and energies now has to go on obviously responding to COVID, but also taking measures, as the ministers referred to, both between now and the year end and beyond, more strategically, to address the reduction of these numbers. That's an unacceptably high level. The gap in the red line is actually loss of data associated with the cyber attack. You can see though that in 2020 particularly, the lists absolutely peaked. You'll also see that even though the numbers are high, the public system, when it recovers its capacity, begins to bring those numbers back down. And we have a strong focus on doing that further. NTPF are buying care for that purpose. I should have said within the safety net, the role of the private insurers, in fact, VHI, have been very helpful and support in running the relationship with private hospitals, and that's been key to us. It's kept the burden of administration away from us that we would probably struggle to handle, to be honest. So from our point of view, our focus going forward is saying, what can we do to reduce these numbers, and indeed the outpatient numbers, which on that chart showing 644,000 end of October data. And you can see from the map spread right across the country. Again, we can sub-analyze that by time to access, but fundamentally those figures are way above where we would have been previously, and where we were previously in 2019 was already an unacceptable position for the population in terms of healthcare delivery. So from our perspective, our focus has to be there, and the private system, private hospitals, I think can play a key role in assisting with that. It's important, I suppose, to remember the system is at the moment, the public hospital system, and indeed community and public health system, vaccination and testing and tracing, as you see in media, are responding heavily to COVID and the impact of COVID right now. Our key issue going forward is access to care, both urgent emergency care and planned care. And that's absolutely clear and very clearly set out for us in Sláinte Care and in the requirements coming to us from government and indeed from and through the Minister. The health system has had unprecedented investment in the last 2 years. I've never seen investment at the scale we've seen. I think it doesn't yet experience the benefit of that investment fully because of the impact of COVID. At the peak in January, February, the health system had over 5,000, about 5,700 staff COVID-related absent. At the moment, that's near 3,000. So the impact of COVID has actually, for the short term, I think mitigated against the benefits of an otherwise very significant investment. We are seeing some of the benefits, having said that, in ICU capacity and increased acute bed capacity. And I think in the medium term, what's happening, as in into next year, what's happening on the expanded community services and moving of care to primary care will become more visible and I think very beneficial, and hopefully take some strain off hospitals in the near term. The public system needs capacity both short and long term, and that's both within itself and in interaction with the private system. So I think really our perspective and our duty in legislation is to provide care to citizens. I think Bill was touching on that. We have a job to do there, and we can do that across both public and private environments, and in fact have in the last 2 years. The NTPF, as the Minister referenced, has an increased budget and is buying and can buy significant planned care from the private system, both in this year and at an enhanced level next year. And we work with the NTPF in terms of the types of work that can move from public hospitals to private environment. We also work with the NTPF to fund activity at a marginal level in the public system where that's feasible. Obviously, in recent times, that hasn't been very feasible. And we also need to remember, as an organisation within the HSE, all patients are first public under legislation, and we have a duty to all patients, and the private system can fundamentally assist us in delivering that duty. So we very much look forward, when we get past this phase of the pandemic, to developing a more strategic relationship that has perhaps a longer time scale to our arrangements and understandings. I think that's something we'd be very keen as an organisation to both foster and develop. And the models of care that we're operating and the work that's going on right now in cardiology and COPD and diabetes, to invest in enhanced services in the community to improve the availability of diagnostics outside of the acute environment and indeed for GPs, that will, I believe, drive shift in the patient flows in future months and years. And I think the role of technology in terms of what we can do within the health environment will also be very significant. I'm not going to say any more about those right now, but I think they could be subject of whole separate conferences. But I think there is an opportunity for us to work on an ongoing basis, I think, closely with private hospitals. And it has certainly been a very beneficial experience for us to do that through from 29th of February last, which was the index case, I would say. And from our point of view, I think going forward, we'll have a key dependence while we're trying to build capacity in the public system. And the National Development Plan has committed very significant resource to that, over 5 billion in the coming years. We can also and should be using the available capacity in the private system. And I would reflect the Minister's observation there. Really, any capacity that we can acquire in the coming year and years, we will need to. And if there's a clear demand, and we will need to meet that demand. So I think, Bill, that was it. I didn't mean to go on for too long, so I hope that's been okay. If I just stop there, the slides I can send on to Bill for anyone who's interested at a future point.
I think if David Neville was listening there, your invitation for a whole additional conference on just the IT and technology, he's already working on it, Liam, so watch this space for that. Liam, I know you're tied up with NEFIT, but I trust you're still going to be available for some questions after the rest of our speakers. Are you still good for that?
Yeah, that's fine, Bill, yeah.
Yeah, good. If we can just throw back up the slide there, just as a reminder for everyone. I'm stuck up here on stage, so I don't know if people are avidly tweeting and making use of the hashtag PHAConf21, but also to remind those who are online to use the Veto live chat platform. I can't see Gillian, but she's capturing all of the questions. There she is. And I will be trying to get through as many as possible during the discussion time, which will be coming along shortly. So, to our next speaker, Audrey Dervaloy, CPO Head and Country President for Novartis Ireland. Audrey was born and bred and brought up in France, mother of 2 children, Olympia and James. I hope I'm saying that right, Audrey. A medical doctor by training, she was inspired by learning in Paris with internationally renowned health professionals. A family project took her to work in Asia, and she lived for 3 years in Hong Kong. She joined Novartis in 2013, and for the richness of its portfolio and the big focus on innovative medicines, and a number of us have worked with Novartis over the years, and we know their reputation in that regard. She went there as head of the medical department in ophthalmology. She moved on to commercial management of the marketing and sales unit. It's an extremely innovative sector, as we know. In early 2020, she was appointed general manager and country president of Novartis Pharma. We're delighted that she's here with us today. We look forward to her presentation. Audrey, over to you.
Thank you very much for the invitation. It's my great pleasure to be with everyone today, and I would like also to acknowledge the fantastic success of a vaccination campaign in Ireland. We have to be proud of this, and I would like also to echo on the fantastic determination and contribution of healthcare workers in the last 21 months. So thanks, of course, to the public sector, but the private sector should be very, very proud of your contribution. So thank you very much for this. It's my great pleasure this morning also to be able to share our vision at Novartis, to rethink about the healthcare system in Ireland and how, as pharma sector, we can contribute. So what the future could look like? Of course, lessons have been learned in the last 2 years, and we need to look at this. The first point is about the private sector. The private system leveraged to enable the public system, and it's clear that we should not see 2 systems, but one to tackle the current challenges. We have also of course, observe some challenges to implement Schlentecare, and it was great to listen to the minister this morning to mention that, Schlentecare implementation is a key priority, and it will be a top priority for the government members. Will we see a shift from acute hospital center to an integrated healthcare system? This is something very important if we want to remove the burden of the secondary care into the primary and the community. Waiting list, it has been already mentioned this morning. It has been a very, it's a big issue. Of course, COVID created extra layer of complexity and challenges and further health inequalities. So it's where we need, to collaborate to make some progress, and this is a top focus for all of us. We all would like to wake up a morning with such a headline. innovative healthcare system in Ireland. I think it's something very realistic, and if we collaborate all together, we can achieve this. Why? Why? Because we have a unique ecosystem in Ireland. Of course, universal public health system, but very important private health system. And all of you online today, you know that the private health system has been an early adopter of innovation. We have also world-class technology companies, medical device companies, strong academia, and also support and funding bodies. So as a foreigner living in this country, I can tell you that we have all the ingredients to make Ireland a leader in innovation and health if we all work as a coalition. Lessons have been learned and how the pharma sector can contribute now. We have seen a very large collaboration between private and public in the last 21 months. What was different this time? For the first time, we have made disease the common enemy, and that's why we have seen this amazing collaboration. The question we ask ourselves at Novartis is, can we tackle chronic disease the same way? Same level of collaboration, same sense of emergency. At Novartis, we have changed our mindset, we have adapted our structure to be sure that we really understand the needs of the society, but also we can co-develop and help and contribute to make some progress. What we need to make it real now? We need to agree common ambition in Ireland. We need to leverage this unique ecosystem to develop partnerships, including new and non-traditional healthcare. We need to build on the digitization of the healthcare. We need to foster clinical trials. Clinical trials, this is very important, and we need to maintain the attractiveness. And we need to create a platform for collaboration with trust and open dialogue, including, again, traditional and non-traditional stakeholders, and as pharma companies, we want to contribute. So what is our ambition at Novartis, and are we all prepared for our healthcare system? If we want to make some progress, we need to start to focus and to prioritize. And where we would like to focus is in cardiovascular disease. In the 2 last years, around 18,000 people died from chronic vascular disease. And this is important to keep in mind that 65% of them are linked to predictable factors. That's why at Novartis, we want to start focusing on cardiovascular disease, and we strongly believe that we can contribute here. We have started, to partner with some stakeholders. We are very pleased to start a partnership with SMART-D8 and also the Irish Heart Foundation, XWell, and Family Resource Center to decrease the cardiovascular disease hospitalization in Ireland in small area, but the objective is to scale this program in the country. We are also very prone to start next year a Biome. So Biome is a platform at Novartis, and we want to bring all the talents and capabilities we have at Novartis for the local market. So we have started, and of course we want to contribute more and more in future. So thank you for listening, and I strongly believe that with this level of collaboration, we can all make progress and impact in Ireland. Thank you.
About how everyone loves your accent. I thought it was mine that they were commenting on, but apparently it's yours. Who'd have known? Can I remind you all again about the hashtag and the tweet, and also the use of the veto function there for any questions. Audrey is going to be joining us back on stage with Liam and with our next speaker. So take the opportunity for any questions you have for Audrey. Let me move on to our next speaker now, Dr. Brian Turner, lecturer and health economist from UCC. I've had the privilege of meeting Brian most recently on a number of occasions, and he gave an excellent input to our recent board strategy day in the Bon Secours, and thanks again for that, Brian. Brian, having spent over 7 years as a property analyst in London and Dublin, joined the Health Insurance Authority. And for those of you who know, the Health Insurance Authority is the statutory regulatory body for the Irish private health industry. He joined that in 2002 as head of research and technical services. In 2005, Brian returned to UCC to study a PhD in economics, focusing on health insurance issues, something that's always been obviously very close to his heart. He completed that in 2010. Like myself, he's a born student. He now lectures in the Department of Economics in Cork University Business School at UCC, including on health and insurance issues. Brian's research has been very widely published nationally and internationally. He's delivered a number of speeches at a number of high-profile events, none more important, Brian, obviously, than the Bon Secours Board Strategy Day. He'd be the first to say that himself. And he is a very frequent contributor to national media discussions on the Irish health system. I know you're very, very much going to enjoy this. So, Brian, hopefully the sound is working, and over to you.
Thanks very much, Bill. I'm not sure whether this trumps the Bon Secours Strategy Day, but it depends on which hat you're wearing, I suppose. So I'm just going to share my screen there, so hopefully you can all see that. Can you? Is that coming up there, Bill? Okay, I'm assuming that everybody can see that. So, so thanks very much, Bill, and good morning, and once again, happy thanks.
Sorry, no one can see yet here. The AV guys are telling me.
Okay.
Can we pull it up from here? Oh, here you
There we
go,
go.
Brian. Yes.
Sorry about that. For a change, I wasn't on mute, but I forgot to share the screen. Minor technicality.
Minor technicality. No, we're good to go now, Brian.
Okay, great stuff. Thanks very much. As a good morning, everybody, and happy Thanksgiving to anybody of an American disposition, or indeed anybody who wants to give thanks for finally getting my slides up on screen, if nothing else. So I suppose what I want to do this morning is just give you a quick spin through the environment, I suppose, in which you're working, and where that might go over the next little while. So to start with the economic background then, one second there now. There we go. So in terms of the economic background, the forecasts this year are for a strong recovery from the pandemic. Now, obviously, what's happened over the last few weeks may slightly change that. So it'll be interesting to see the latest round of forecasts over the next few weeks and months. But prior to that, the forecasts had been upgraded during the course of the year in terms of the recovery from the pandemic, albeit not an even distribution of that recovery. So people are talking about now what they call a K-shaped recovery, whereby some sectors will recover quite well, other sectors not so much. Now, I suppose the sectors in particular, and the last few weeks have shown, again, even more so, the sectors that are at risk would include hospitality, the nighttime economy, and so forth. So, I mean, in some cases, those sectors tend to be on average lower paid than some other sectors. So it may not necessarily have a huge impact on private health insurance take-up, which is obviously one of the key metrics from your own point of view. But it will, I suppose, have some impact on some people in those sectors. The other big issue in terms of the economic side of things is the state of the public finances. Now, the government has borrowed heavily over the last couple of years to try and support the economy and to pay for the health system during the course of COVID, and rightly so, it must be said. But as we learned very, very clearly over the last decade, when you borrow money, that has to be paid back. Now, at the moment, we're borrowing at record low interest rates, in some cases pretty much zero interest rates. When that debt is rolled over, if it is rolled over, we won't be so lucky in terms of the interest rates that we'll be paying on that. Or if the debt is paid down, then taxation needs to increase in order to pay that down. Now, some of that will come from the economic growth, but there may potentially be some tax rises down the tracks in order to try and recoup the money and pay back the government debt. Now, obviously, if taxes are increased, that will have an impact on household budgets and affordability of private health insurance. It will also have an impact on health spending in terms of the government health spending. Now, I suppose overall government spending may need to be reined in, but once we get past the pandemic, and hopefully that will be sooner rather than later, then health will be competing with other priorities such as climate change, housing, infrastructure. So the focus might shift off the health system, and we I suppose we'll need to kind of keep the pressure on to have the health spending maintained at the level at which it needs to be maintained. Now, obviously, a lot is going to depend on how much longer the pandemic lasts. And as I said, the last few weeks have shown us that, just as we thought we were kind of starting to come out the other end, there was a bit of a sting in the tail. So this could last quite a bit longer than people had been forecasting. So it's about how we actually cope with the pandemic and in terms of the economic recovery. In terms of private health insurance, which is obviously a key area of interest for the private hospitals, the good news is that demand is currently pretty robust. We're at record levels of take-up in terms of the numbers with insurance, albeit that the take-up rate as a percentage of the population is lower than it was at the peak in 2008. Simply because the population has increased since then. So at the moment, we're about 46.5% coverage. At the peak in 2008, it was just under 51% coverage. But it is still pretty good. I mean, it's one of the highest take-up rates of health insurance, of the kind of health insurance that we have in the OECD. Now, not surprisingly, it's correlated quite a bit with employment. You can see there over the last 20 years, pretty close correlation with employment. Okay, there was a bit of a decoupling during the last recession. There was a bit of a lag in terms of the peak and a longer lag in terms of the trough. So the numbers with insurance troughed in 2014. Then you saw the one-off increase for lifetime community rating, which was introduced in May 2015. Since then, the growth has been pretty solid, not quite as strong as it was pre the last peak. So even though the numbers are increasing, they're not increasing as fast as they did during the Celtic Tiger days, but it is definitely increasing. So obviously employment is a key take-up. The waiting list figures, and these have been talked about already, and they certainly point to continued demand for private health insurance. So even though the waiting list, the number on the waiting list has improved in recent months, the numbers waiting longer than a year are still a little bit higher than they were in some cases before the pandemic started. So I don't think there's going to be a mass discontinuation of health insurance anytime soon because of the waiting lists, which are one of the key drivers of demand for health insurance, as I'll mention again in a little bit. The other issue is the uncertainty over the implementation of Sláintecare, and I suppose that hasn't been helped with the high-profile resignations from the implementation body and the advisory council over the last number of months. So there is a little bit of uncertainty in terms of the rollout of Sláintecare. I mean, the uncertainty, I suppose, is more in terms of timing and the extent to which it's going to be rolled out over the 10 years. So again, the environment is such that I think the demand for health insurance is going to stay pretty robust for the foreseeable future. In terms of the market itself then, you can see there from the graph on the right hand side, the largest cohort within the health insurance market is the under 18s. that's partly a feature of the fact that that age category is broader than most of the other age categories. In terms of the adults, then you can see that the largest number come from those in their 40s, and the numbers tend to drop off after that. But again, this is partly reflecting the population bulge in middle age groups. So in terms of take-up rates, as a percentage of the population in each age cohort, the rates are lower than average under the age of 40 and over the age of 85, and they're above average basically between 40 and 84. The take-up rates generally tend to increase from 30 onwards up until the 75 to 79 age group, which is has the highest take-up rate of any of the age groups. Now, why does that matter? Well, if you look at the average claim costs by age, you can see that it increases pretty much exponentially at older age groups. So the average there is €870 per person. So all the age groups under the age of 60 are below that average. All the age groups over the age of 60 are above that average. And as you get up through the age groups, the claims costs increases quite rapidly. So that's obviously why age is a significant issue in terms of take-up for private health insurance. So why are people taking out health insurance? Well, the HIA commissions a survey of consumers every 2 years to gauge attitudes towards health insurance. And these surveys are delivered to people with and without health insurance. But one of the questions that's asked of those who do have health insurance is why they take out health insurance. So the findings are pretty consistent over time. So these are the findings from the most recently published survey, which was published in 2020. And they show that the most commonly cited main reason for taking out health insurance was the cost of treatment and accommodation. Now, presumably that is the cost of treatment and accommodation in the private system, because the cost in the public system is relatively modest. I mean, if somebody has a medical card, there's zero cost in terms of hospitalization. If somebody doesn't have a medical card, it's €80 per night, up to a maximum of €800 in any continuous 12-month period. So relative to the cost of to the cost of providing treatment, that's a fairly modest co-payment. So that's the main reason, that just a way of paying for the cost of private treatment if people need it. The second and fifth most commonly cited main reasons there both relate to the perceptions of the adequacy of the public health system. Now, it's interesting that the inadequate standard is ranked higher than the lack of access, because the reality is that most people who are treated in the public health system are very happy with the quality of treatment they receive. The problem is the access. So the fact that the standard is rated higher in terms of the driver of demand for health insurance than access suggests that maybe there's a perception issue there rather than necessarily reflecting the reality. The third and fourth reasons there essentially are kind of, to a certain extent, outside of people's control. So either it's paid for by their employer or parents have included people on their policy. In terms of the characteristics, the vast majority of people in the health insurance market have cover for private hospitals, which is obviously a key interest for yourselves. So the level 1 products are those that cover public hospitals only. So only 9% of the population of the insured population have those products. The vast majority of the insured population who do have private hospital cover have the level 2 products, which cover a semi-private room in a private hospital. The level 3 products and above, about 1 in 6 people have those. So they're the plans that cover private room in a private hospital, semi-private room in a high-tech hospital, or a private room in a high-tech hospital. So levels 3, 4, and 5. About nearly two-thirds of the insured population have plans that have the restricted cover for the orthopedic and ophthalmic procedures in private hospitals, and not surprisingly, that tends to be concentrated in the younger age groups. So the older age groups, who are the ones who are more likely to need that cover, are less likely to have the restricted benefits in private hospitals on that. And that's 65% of people with those restricted benefits. That number has been increasing over the last number of years. So it'll be interesting to see as those people age, will they opt to move back for the plans with the greater cover for those. So in terms then of the claims and where they're being spent, I suppose 2020 was a bit of an unusual year, obviously because of the HSE takeover of the private hospitals for the 3 months. So 2019 is probably a better gauge of what might be termed a normal year, if we can ever get back to normal again. And you can see there that nearly half of the claims spent on private health insurance were spent in private hospitals. And that's excluding the consultants, which are a separate category. Now, what we've seen over recent years, up to 2019 at least, was that the spending in the proportion of spending in private hospitals was increasing, and the proportion of spending in public hospitals was decreasing. Part of that is down to the insurers pushing back against the charging of patients in public hospitals, even if they don't get any benefits of health insurance. So if somebody goes into a public hospital via A&E, they're not getting faster access. If they're treated by the consultant who happens to be on duty, they're not getting a choice of provider. And if they're accommodated in the ward, they're not getting the superior accommodation. So they'd be the 3 benefits, the typical benefits of health insurance, the type of health insurance that we have in Ireland: faster access, greater choice of provider, or superior accommodation. So obviously what the health insurers are saying to their members is, look, if you're not getting any of these benefits, don't sign up as a private patient, because we're getting charged for essentially what you're getting that you would be entitled to as a public patient anyway. So again, very much kind of a concentrated on the private hospitals in terms of the claims. Looking at the broader picture, taking a step back and looking at the CSO system of health accounts figures, what we can see is that private health insurance is very much more hospital oriented than either of the other main sources of funding for the health system. So the latest figures show that nearly 3/4 of funding for the health system comes from the government, about 12% from private health insurance and 12% from out-of-pocket payments. But you can see that there's a much greater spread of government expenditure and out-of-pocket payments than there is for private health insurance. So certainly there is potentially scope there for health insurers to broaden that out a little bit if they want to contribute to the reorientation of care away from hospitals and more towards primary continuing community care. So that brings me then to Sláinte care, which is the other big issue of relevance. So as was mentioned earlier on, I mean, it's hard to believe it's almost 4.5 years. It'll be 4.5 years next week since the report was launched. Now, that being said, 2019 is essentially being considered year 1 of Sláinte care. So it wasn't that year 1 was 2017. The idea there is the holy grail, if you like, of a universal single tier health system, whereby people are treated on the basis of need and not ability to pay. The important word that's missing from that definition, which is from the report, is a universal single tier public service. So they're not for a second suggesting that there will be just one single tier system. They're talking about a public system that is single tier with a private system operating alongside that, but just with greater separation between the public and private systems, because it's not unusual to have a mix of private and public funding and delivery. Where we are unusual in Ireland is in the degree of overlap between the two. And one of the key planks, if you like, of the plan to separate out the public and private systems is the removal of private practice in public hospitals. The other big change in the health system envisaged under Sláinte care, as I said, is the reorientation of the system more towards primary continuing community care. Now, that's not to say that they're envisaging a reduction in hospital treatment. They're actually envisaging an increase in hospital treatment, but just a greater increase in primary continuing community care treatment. In terms of the costs, the figure has been bandied about again in recent times, the €2.8 billion per annum additional spending by year 10, but that's over and above the additional costs arising from medical inflation and demographic pressures of the ageing population. Now, the report was allowing about 3% per annum for the medical inflation and demographic pressures, which I think is probably a little bit conservative. I think it may well be a little bit more than that. There was also the transition fund of €500 million a year for the first 6 years. But one thing that is interesting and didn't get a whole lot of traction because it was just kind of buried deep in the bowels of the report that only the anoraks like myself would probably see. There was a partial offset of this extra €2.8 billion public spending. The partial offset was nearly €1.5 billion a year less in private spending by households, arising from a reduction or removal in a lot of the user charges, so things like reductions in the drug payment scheme threshold, the prescription charge, the removal of the statutory bed charges, and a reduction in the A&E charge, and also lower demand for private health insurance. Now, this 1.482 billion figure was just dropped in at the end of a paragraph in the middle of the report. No indication of the assumptions underlying it. What the forecast was for the reduction in demand for private health insurance. There was no detail at all. It was just literally almost in there as an afterthought. But it's something just worth bearing in mind. In terms of the capacity, I mean, the capacity figures are fairly eye-watering. They're basically talking about roughly a 20% increase in hospital bed capacity and consultant capacity, and then even greater increases in primary care. So, as I said, there's an increased forecast in the hospital treatment, but a larger increase in the primary care treatment. And bear in mind, these are net figures. So we keep hearing about the number of people who are likely to retire from the health service over the coming years. So these figures are the net increases that they're expecting. So the absolute increases are going to be even greater. In terms of the challenges to Sláintecare, obviously funding is a big issue. So in fairness, and the Minister referred to this earlier on, there was a big allocation in Budget 2021, which was announced in October of last year, to try and allow for increases in capacity. So that was very welcome, but obviously the pandemic has kind of muddied the waters in terms of the whole funding issue, and obviously once we get past the pandemic, it'll be interesting to see does that funding still carry through, because there is significant increase in funding forecast right throughout the 10-year time frame of Sláintecare. And obviously the fiscal retrenchment that I mentioned earlier on post-pandemic could well affect health, because there could be an overall reduction in government spending, and then there will also be greater focus on other areas of government spending. In terms of the capital infrastructure, the National Development Plan has allocated funding for health, but given the recent record on large health-related capital infrastructure projects, shall we say, then it looks like the funding that's allocated under the National Development Plan may not be sufficient for the scale of increases that are required. The elective-only hospitals, the most recent Sláintecare implementation plan, or the report on the Sláintecare implementation, which kind of got a little bit buried with the resignations from the implementation body, that suggested that by 2023, the 3 elective-only hospitals will have gone through planning, gone through tendering process, and be under construction. Now, I think that is very optimistic, to put it mildly. So I don't see that happening within the next 2 years. And I think the cost increases are probably going to be, it's going to require additional money. I mean, if you think about it, before the pandemic hit, tender price inflation was running at about 7% a year. So we have a construction sector that was hollowed out during the course of the recession, post the financial crash. And we now have huge demands on that construction sector, not just in terms of health, but the greater public infrastructure scenario. You've also got massive pressure in terms of housing demands, and the commercial property sector was fairly robust prior to the pandemic, at least, as well. So I think tender price inflation is probably going to keep going. So every year that there's a delay is going to add more costs onto these capital projects. The other big issue in terms of Sláintecare is recruitment and retention. Now, as I mentioned, you're looking at very significant increases required right across the board, both in hospitals and in primary care. We're trying to increase our medical workforce very significantly in the context of an international shortage of healthcare workers. So there was a report came out 2 years ago suggesting that by 2030, there was going to be an OECD-wide shortage of about 386,000 doctors and nearly 2.5 million nurses. So it's within that environment that we're trying to significantly increase our healthcare workforce. And judging by the reaction to the draft Sláintecare consultant contract, I think there will be challenges in terms of recruitment and retention. So I think the consultant contract, which I think is probably going to be one of the key deciding factors as to whether Sláintecare flies or falls. I think that the negotiations are going to take a lot of time, and I think they could be quite interesting to follow over the next couple of years. Just a quick word on the ESRI projections. So the ESRI have taken the demographic projections for population growth and population aging, and they've put that through their Hippocrates simulation model, and they forecast a projected need for somewhere between 3,200 and 5,600 public hospital beds. So even the lower range of that estimate is higher than the 2,600 beds envisaged by Sláintecare. And they're also looking at somewhere between 780 and 1,200 additional beds in private hospitals, with a higher proportionate increase in inpatient beds than day beds. So obviously that's going to be of relevance to yourselves. So in terms of the outlook, just to finish up on this, I think certainly demand for private health insurance is going to remain strong for the foreseeable future. I think people will wait to see the improvements in the public health system post Sláintecare before they decide to discontinue health insurance in any great numbers. I think Sláintecare, I think it's pretty much widely accepted now that Sláintecare will not be fully implemented within the 10 years. I think it was always going to be very optimistic to hope that it would all be done within the 10 years anyway. So the key question is, to what extent will it be implemented within the 10 years, and which bit of it will be implemented within the 10 years? In the shorter term, and again, I think the Minister has mentioned this, and Liam Woods mentioned this as well, the need for the private capacity to help out the public system in terms of waiting lists, so through the NTPF, and obviously the calls on private capacity during the pandemic. So I think in the shorter term, that will continue. I don't see any easing of that anytime soon. And the biggest issue, I think, is going to be capacity, not just in the public system, but also in the private system. So if the private treatment is removed from public hospitals, then that's obviously going to increase demand in the private hospital system. Now, having said that, the amount of work that will be transferred over is less than some people might think, because the vast majority of private work that's carried on in public hospitals is patients who've gone in via A&E, who've just signed a form to say they have health insurance. So if private practice is removed from public hospitals, those people will likely still go in through public hospitals, but just be treated as public patients. So what's going to be transferred over is the private elective work that's carried on in public hospitals. And the ESRI has estimated that is taking up just over 3.5% of inpatient bed nights in public hospitals. So it is, I mean, it's still a significant amount, but it's less than I think some people might expect to be transferred over. But obviously the capacity will be needed in the private system to cater for that, to ensure that private waiting lists don't start to increase post the removal of private practice from public hospitals. So I'll finish on that, and happy to take any questions during the discussion. Thanks very much.
Very informative. We have a number of questions coming in, but if at all possible, could we, 300 people, give a virtual round of applause to 3 excellent speakers, please? I don't know how we do it socially distant, but I thought they were all excellent and very thought-provoking. So we're joined now, if you can picture the scene, myself and Audrey here on stage, and Liam and Brian virtually to form the panel discussions. As David Neville said, what could possibly go wrong? A number of questions coming in no particular orders. Liam, I might start with a very specific one. In your slide, you used a phrase, all patients are first public. Can you just elaborate a bit?
Thanks, Bill. Yeah, the round of applause, Bill, I guess, well, I don't know, can people show hands? That's the way we've gone back in other meetings. But from my point of view, when I'm saying that, what I'm referring to is that every resident in the country has an entitlement to access public health services. And so from our point of view, and maybe just picking up on the point a few moments ago from Brian, we have to have capacity or capability to provide service. And when we talk about access, our duty is to provide service to everyone who's resident in the country who presents to us. You might well say we struggle to do that, and we've struggled more in recent years, and that's entirely true. But the legislation, the 1970 Act, gives that entitlement to people. They can negate that entitlement or choose differently, but we have a duty in that regard.
Thanks, Liam. A question probably for Liam and Brian. Maybe Brian, you could start. Sláintecare, we're all aware of it and when it was launched and broadly what it sets out to achieve. Our next speaker will be talking about some of the research that the PHA commissioned in terms of the public attitude towards Sláintecare, its understanding and what the public might expect from it. Your presentation, Brian, you sort of, some of the questions coming in are centred around, will Sláintecare be delivered? Has the timetable slipped? And if so, is it being recast? I think is the form of the questions, Liam, that are coming in. But Brian, first, you were part of some of the original discussions on Sláintecare. Do you see it being implemented within the original timescales?
I don't think there's any realistic prospect of it being fully implemented within the 10 years. As it would have been challenging at the best of times, but I mean, you know, throw in a pandemic and a cyber attack in the middle of it, and I think it becomes virtually impossible to fully implement it within the 10 years. So, as I said, the big question is to what extent will it be implemented and which bits will be implemented within the 10 years. Now, that being said, I don't see Sláintecare being ditched. Certainly, I don't think there's any alternative to Sláintecare, any realistic alternative. I think we will probably continue along the path, but it will take longer than the 10 years. So I think, you know, there is still a commitment. My sense is that there is still a commitment to Sláintecare, but just the challenges in implementing it will mean that it will take a bit longer.
Liam, I would have thought the obvious impact of coronavirus was going to affect the timetable for anything, and clearly it will be having an impact on Sláintecare. But your thoughts?
Thanks, Bill. Yeah, I mean, I think in a sense, many things have been set back by the last 2 years' experience. I think the Sláintecare, having said that, the last 2 years have accelerated some things also. I had said during the presentation, we haven't seen investment scale we're now experiencing. Certainly in my time in health, I haven't seen the scale of investment that we've had in the last 2 years. I do think it's correct to say, and Brian covered in his presentation, what's happening in building timescales will challenge us. The delivery of, having said that, some key components of Sláintecare to me still seems very feasible and possible. The biggest challenges we face are around construction and recruitment and retention. And then we've a lot of work to do on change models of care. The point about private work and public facilities, I think Brian's comment, I'd very much echo that most of the private work coming into public facilities comes through the emergency department. So that work, unless there are other emergency departments doing what public emergency departments do, is unlikely to shift anywhere. And that's actually the bulk of private activity in the public system. So from my point of view, I think some pieces of Sláintecare can run. The challenges will be probably around completion, construction. Capital availability, actually in the National Development Plan, is certainly there to enable us to drive at things like the elective hospitals and increased acute capacity. Brian had picked up the point, Bill, that the models of care that are being realised through the Sláintecare thinking process and implementation are about shifting service to community, but also still anticipating a need for 2,500 or more beds. And in fact, the SRI study just before the end of last year was flagging that number may be rising a bit. Thanks, Bill.
Yeah, if I can just stay with Sláintecare for a bit longer, Audrey, some of the questions coming in, or one of the central planks of Sláinte Care is a move from acute to primary care. And the questions are centered around what do you think medtech or pharma can do in helping manage that transition, and are there any things in the pipeline that we can look out for?
Yeah, thanks for the question. I think this is an important topic, and of course, you know, in pharma sector, we want to contribute, and where I guess we can contribute in this transition phase is to have a good understanding regarding what are the burning points, being all together, having again, you know, this open dialogue, and be sure that, you know, we can bring our talents, our expertise to tackle all the burning points. So. For me, this is about, you know, having a very good understanding regarding the patient pathway, all the burning points, bring our expertise, and be sure that we are also seated on the table to bring, again, our medicines, but not only the medicines, but also our technologies and capabilities.
Excellent, thank you. Liam and Brian, I think you both touched on the additional beds that would be needed in both the acute hospital, the public system, and I would argue in the private system as well, Liam. And of course, the private system would be interested in planning and modelling that in conjunction with the HSE to help inform our investment decisions. But if I can leave the beds and the bricks and mortar to one side for a second, most of the questions are coming in about we're going to need another 500 to 600 doctors. We're going to need more nurses, every allied health care professional you can think of. The challenge, I suppose, Liam, is where are we going to find those people?
Yeah, thank you, Bill. So the workforce planning for what Sláinte Care proposes is very significant and actually is underway within the HSE. But the attraction and retention of staff of all grades, particularly doctors and nurses, but health and social care professionals and others, is a major challenge. We're seeing that at the moment. We have grown in the last 2 years by over 11,000, and that would include some significant growth in both doctors and nurses as well as other grades. So there is some sign that that's possible. We do come back to look at training numbers within our environment, what's our retention look like. The Royal Colleges have studied the propensity for doctors to go overseas and potentially to return from overseas. So I think all of that is important. But I think it's fair to say the biggest single challenge is the international competition Brian referred to for staffing. And we're experiencing that at the moment. So the workforce planning, which we're engaging in through our own HR and across our services, is looking to see how we address that as we expand. At the moment, we continue to recruit both locally and internationally, but that is against very stiff competition, no question about it.
And Liam, I'm keeping an eye on the texts that are coming in here now. Maybe something to reflect on and talk at a future date, but do you see any opportunities for progression of joint consultant appointments to public and private system, given the rise of the Sláinte Care contract?
That is one to reflect on, all right, Bill. I think the idea of a joint plans to deliver against what is a public health need and how we deliver that in contract terms is something to think about. I wouldn't go much further than that at the moment.
No, we'll put that on our to-do list, I think. Brian, on the off chance that you actually have the knitting pattern for nurses, do you have any thoughts as to how the economy is going to help deliver this in terms of the emigration and immigration and the war for talent? I think this is a key issue for Sláinte Care in terms of we can build beds. That's not the hardest part. Staffing them and having the expertise to give the care is the real challenge.
Yeah, I suppose there are a couple of things there that I'd point out. I mean, one is that kind of paradoxically, we have in Ireland the highest rate of medical graduates per capita in the OECD, yet simultaneously we have the third highest rate within the OECD of doctors working in our hospitals who have been trained outside of the jurisdiction. So there is that kind of that tension there. Now, one thing that really encouraged me, and it's a potential silver lining of the pandemic, is the response to the Be On Call for Ireland initiative last year. So that suggests that there is a lot of goodwill towards the Irish system among Irish medical graduates who are working overseas. No, in terms of the recruitment and retention, I mean, a lot of focus is on the consultant contract and the pay issue, but from speaking to healthcare professionals, it's not just about the pay; it's about the conditions as well, and in particular the pressure that the public system is under. So I think if we can reduce that pressure, if we can make the investment, if we can increase the capacity and start getting through the waiting list, I think that will generate some momentum there, and it could become a prophecy that as we improve the public health system, not only are patients more likely to want to go into the public health system, but also staff as well. So I think there are positive signs there.
And staying on the economy, Brian, in terms of projections for the economy, and you mentioned that we're constantly looking at it and look to recast it. Where do you see the recovery in the next year and the next 2 years? And if you can predict that, will you tell me the lottery numbers for Saturday as well? That would be handy.
Well, I think that there's been a lot of talk about the lottery at the moment, and people clearly don't understand probability and statistics. But in terms of the economy, it is an interesting one. As I said, the projections for the recovery in the economy were actually being upgraded during the course of the year. What we're seeing now is that obviously the pandemic is going to last a bit longer than a lot of people had forecast. So that may actually take a little bit of the edge off the recovery projections. But certainly one of the things that we have seen during the course of the last 21 months or so is a big build up in personal savings. So that money will be looking for a home once we come out the other side of this. So I think that will drive a lot of economic growth in the domestic economy. So I mean, obviously in terms of GDP numbers, we've seen a very strong recovery in those already, but a lot of that has been driven by the pharma and tech sectors in the economy. So it's once we see the domestic economy, particularly consumer spending starting to increase, that we'll really see the recovery taking shape, I think.
Thanks, Brian. Liam, we are getting quite a few questions in about the HSE's winter plan, and winter comes every year, and this year and last, exacerbated by coronavirus. Can you give us a bit of detail of what's in the winter plan and what might be different this year, given the challenges we face?
Thanks, Bill. Yeah, the winter plan, as you say, Bill, there's a great predictability in many ways, with the exception of COVID, around the patterns within the health system. So the notion of a winter plan really for us is just about focusing on what can we do that's additional now that supports services, both hospital and community, to bring us through into 2022. In reality, the winter plan for us in funding terms is really part of the service plan for 2022, which is just being submitted to the Minister at the moment. So the financial provision in the winter plan is 77 million. The main pieces of that, actually, there's 20 million of that, which would include acquisition of service in the private sector. There's a significant piece, I think 22 million, related to transitional care in community, so movement from acute to community environment and supporting that. And then there are quite a number of projects that will be flow related around supporting movement between hospital and community, and indeed within hospital. But recognising, Bill, that there's no winter plan that's going to resolve the capacity challenges the health system faces in a winter. So what we're doing simply is advancing what we can advance that will make a difference in the near term, while the overall service plan of the HSE is considered by both Minister and Government.
Thanks, Liam. Audrey, a few questions coming in from different members out there online regarding clinical trials, and two facets to them. One, given the amount of pharma industries are located on the island of Ireland, are we doing enough in terms of clinical research in general? And in particular, a sort of follow-up question to that, what role can the private hospitals play in further encouraging clinical research?
Yeah, thanks for the question. The response clearly is no. I think we can do more. And, you know, the objective of today is what we can do, you know, for, you know, better patient outcomes. And definitively, we need to maintain the investment in research, in clinical trials. Of course, you know, it's not only about public. We have strong academia in Ireland, but we have plenty of examples around the world where private sector is a key contributor in clinical trials. So I guess if you look at, you know, the large presence of pharma sectors in Ireland, it's where we can do more and have a big focus. And it could be, you know, in oncology, it could be, you know, in cardiovascular, it could be in many disease areas, but we need to prioritize this and to work. I mentioned earlier, you know, the coalition, and it's a big topic where we can make some progress, and we have to, honestly.
David, you're not being asked a question here, but do you remember a while ago we actually had a pharma conference? I think probably overdue one of those again. Clinical trials at the heart of it.
Yeah.
I'm InvestNet's agent here clearly today. In terms of safety net, Liam, a lot of discussion about that. We're in a version of safety net that some of us call cyber safety and some of us call safety net light. One of the questions that's coming across, obviously from Private Hospital Association members in particular here, the current safety net agreement, I think, expires sometime around 12th, 14th of January, something like that, based on, we signed it 12 months ago. What, firstly, is your thoughts on safety net itself? We're all watching the three triggers that we once signed up to in terms of transmission rate, hospital admissions and ICU admissions. I think as of yesterday, 2 of the 3 of those conditions are met. The ICU one, which is obviously getting a lot of attention, and the transmission rate, to be fair, has been met for a while. And we're getting ever closer, I think, to the number of acute hospital admissions. So first question is around, do you think we'll be likely to trigger safety net anytime soon? And if so, we'd love to hear from you in the Private Hospital Association and the department. And the second one, similar question, can you foresee HSE, department, government looking to extend safety net beyond January?
Okay, Bill. I think in terms of the second question, the extension beyond January, yes, I think it would be very much in our collective interest and in patients' interest that we would have dialogue to do that. We've already engaged in some discussion on that ourselves, and indeed with colleagues in the department. So I do think, subject to government decision, that is something that we would favour, but I understand government would be very keen to do that too. In terms of the trigger mechanisms for safety net, as you rightly say, though, we're in what we would refer to as CyberNet or Safety Net 3. So we're responding to what happened in May, June time within the HSE. And under that arrangement at the moment, we are availing of services in the private hospitals and are keen to do more under that. In terms of triggering the original safety net, and some of these discussions may need to go a bit more in-house, Phil. The key triggers, as you identified, transmission rate, and we were alert to the fact that the Delta variant was little known at the time the original arrangement was entered into, and clearly transmission rates have moved very significantly. So as you rightly say, we're well ahead of the transmission rate, which was We're looking at that and saying if we need to trigger because of the capacity requirement of the public system and not being able to meet that in the private environment, then we could trigger safety net 2. But in fact, we're quite happy if we can to continue to work under the current arrangements. They are working well for us and hopefully for the private system, and then contemplate a new arrangement which meets a new time period, as you say, after mid-January 2022. So, but our intention at the moment is to use all the capacity that we can avail of within the private system under current arrangements.
And pretend it's just me and you talking now, Liam, and there's no one else here. We probably need to be meeting soon in the next week or two, do you think?
Yeah, just you and I, that's good, Bill. 300 people
okay.
would be a few too many. Yeah.
Excellent.
Thank you.
In terms of a question that everyone is thinking and many people have asked, and I'm going to throw it open to all three members here. We're looking at government's response to the growing transmission rates. We know that we've been asked to double down on the public health guidance. You all know we're here virtually as opposed to in person today, and we thought that was the right thing to do. We're all looking to reduce our number of social contacts and do the hand washing, the mask wearing, the social distancing, etc. But a question for here and perhaps everyone in the audience: do we think we're headed for another lockdown? Brian, there you go. Will we get Audrey to go first?
I don't mind.
Over to you, Brian. You're a gentleman.
Are we headed for another lockdown? I suspect not a lockdown like we had in sort of January of last, or that came in at the end of December last year. I don't see us going back to that level of a lockdown. Are we in for more restrictions? I think the answer is yes. The extent of those, very hard to know, but I don't think we're in for a full lockdown. I certainly hope not. I think people's, patience is kind of running thin, and I don't mean that in terms of people getting sick and tired of the government's responses. It's more, I think, people's patience with oh God, here we go again, and I think adherence to any further restrictions may not necessarily be as good as it has been in the past, but I can see us not having some form of additional restrictions over the coming weeks. But I don't think full lockdown. At least I hope not.
You've got all your Christmas shopping done already, Brian, just in case?
Some of it anyway.
Audrey?
Yeah, same hope. I hope we will not, go for full lockdown as it was. I'm quite optimistic by nature, and I think what is different this time, we have a vaccine. We have seen a fantastic vaccination adherence in Ireland. We have a booster campaign ongoing. So finger crossed. I think we need to trust everyone living in this country, being reasonable, appropriate behaviors. We will get there, hopefully.
I'm going to come back to the vaccines pieces, a few questions on that. Liam, you're very close to, I suppose, one of the biggest dynamics is we're all, rightly so, trying to make sure that the health system, public and private, is maintained throughout the pandemic, and I suppose further lockdown is the ultimate deterrent there. But from where you're sat and the audiences that you keep, and without betraying NPHET and confidences in any way, do you think we're headed for another one?
I think, Bill, we're actively trying to avoid that societally. There's no question the pressure on the hospital system, public hospital system, and I know that has a reflection on the private system also, is increasing. There's some signs in recent days that the data may be just leveling, but that's too early biologically. So if the data keeps if this improves, I think it raises that question, because we're at the limits or close to the limits of what can reasonably be done to provide service. The key challenge for us is avoiding it, and that's about the booster program and public behaviour. And there are signs that public behaviour is changing, which I think are a little bit hopeful. But really, for us, it's a week-on-week review of what the information is telling us about disease incidence and transmission.
Thanks, Liam. Audrey, on the vaccine piece, it's a clear central plank of our response to coronavirus. And yes, we rightly should celebrate Ireland's relative success compared to the rest of the world, and it's good that the booster's been going. But again, for pharma, is there anything else in the pipeline that's going to help? Is there anything else that's coming? How do you see the development of vaccinations? It's been really great to see how we've responded and created this vaccine in record time and the positive impact it's had. What's your thoughts on vaccination development into the future, beyond just coronavirus, obviously?
Yeah, I think it created strong awareness about, the importance of vaccination. And I have to admit that before COVID, maybe, we didn't speak a lot about vaccination. So I think it has increased the awareness and the needs of vaccination. Education as well, if you look at, how the society has learned a lot about vaccine in the last 20 months. I think it's something good as well, because, I'm not so sure we focus a lot on education, how we educate the society about the needs of vaccination. We have, as you mentioned, we have developed, but not only developed, but also approved vaccination in a very short period. So I think it's also good lessons for everyone. But, when we have made, the common enemy, we are able to develop and approve and manufacture the vaccine. So it's a complex process. We have learned a lot, so now it's more how we can build on this and be sure that, we will not come back to the previous world, because we should keep the same speed in terms of access to vaccination across the world. So it's more about what we will do with these learnings now and be sure that we will not come back to the previous world.
No, I think everyone would echo that. Keep doing what we're doing. It's working, and exactly. We don't know what the next challenge we're going to face. One day we'll be looking at coronavirus in the rearview mirror, but what will be coming next? And as a species, we need to react to that, I think. I don't have any more questions coming in. I want to take this opportunity to thank Brian and Audrey and Liam for their very thought-provoking presentations, their responses to their questions. We will be making the slide decks available, and I'm sure that people will have interest in those. I think it's been very informative today. I want to thank them and give them that virtual round of applause on your behalf. We're ahead of ourselves in terms of time. We'd built in a lot of safety time, allowing for technology and all of the moving parts. I'm going to be handing over to Emma Balmain next for the next session. Everyone knows Emma, but just in case you don't, Emma is the Chief Executive of John O'God's Hospital, the country's leading private mental health facility, based out in Stillorgan, out in South Dublin. Emma's been a member of the Private Hospital Association since Adam was a lad, and we've soldiered through many things together. So Emma will be doing a much better job than I've done, and I'm looking forward to all of the discussions that she's going to be chairing and the panel discussions. What I'm going to suggest is we take our break there now. By my watch, it's just after 10:30. Can we all come back at 11 o'clock? That will give us half an hour to refresh ourselves, and we will be back in the room with Emma, and then that exciting bit of research I talked to you about earlier that we commissioned from Oisin Byrne. Emma will be taking us through that. Thank you very much. See you all back here then.
Great stuff. Yep.
Good morning again, everybody, and I'm delighted to introduce you to our second session of our Private Hospitals Association conference this morning. And the first speaker we have is Oisin Byrne. Oisin is from iReach, a graduate of Trinity College Dublin, and he's co-founder of iReach Insights, which is a leading research and market intelligence agency with offices in Dublin and London. And before founding iReach, Oisin has held senior management and director level roles with international blue chip companies such as IBM, Mises, Reuters and Gartner. And the Private Hospital Association commissioned Oisin to conduct research on the general public's understanding of Sláintecare and of its goals. So we're very much looking forward to hearing about your findings, Oisin, and I'll ask you to come up to the podium now. Thank you.
Thank you, Emma, for your kind introduction, and thank you everyone for the invitation here today. I'm going to bring you through the key findings and just put into context the actual research itself. So we run, again, I'm not going to bring you through all of this in detail, but I just wanted to highlight two key points of this, which I think is important when you consider the findings of this research. It's nationally representative, which is hugely important by age, region, gender, and socioeconomic demographics, which means that any of the insights and findings we can take from this research, we can estimate the adult population figures for all of this this research. So I think it brings that extra dimension of scale and how we translate what you will find hopefully is some really interesting insights to the whole country and the challenges that we're facing. The other thing I also wanted to highlight, it's a sample size of 1,000 responses. So we run this model every 2 weeks. We call it an omnibus, and it's used for a lot of polling. We work with many government departments, many agencies, many big brands, pharmaceutical companies, and so on. And that robustness is hugely important in terms of the data, and you can hang your hat on this data. So when we look at the statistics behind it, its margin of error is between 2 and 2.5%. So whatever you see here, the worst case scenario, the real figure is 2.5% less, or 2.5% more. So it's incredibly accurate from a research perspective. And that's where, you know, we get a lot of coverage in the media, because the media and everyone who sees this data really appreciates its validity, its robustness, and its statistical strength. So I'm going to bring you through this. I'm going to try and highlight it's a fairly punchy survey. We actually ran it, would it be about 18 months ago? I think the original event, or so your conference for 2021 was around March. I think I think when COVID hit, it was a week or two before the event. And we ran very similar questions with input from Bill and the guys in Q4PR. And one of the actually interesting things is the stats have changed very little. In a year when we've gone through such incredible change in the Irish marketplace in terms of the health services, private and public, and so on, the demands that have been placed on that, actually the data this year is almost identical to what it was last year, which is kind of one of those unexpected outcomes. So the first question, how would you rate your knowledge of Sláintecare health proposal? And we asked them from a scale of very good to very poor. And you see the first figure, which is pretty stark, 65% say their knowledge of Sláintecare is poor or very poor. When we look at, and again, some of you may have interest in some of the regional statistics behind this, that's highest for those living in Munster at 72%. So 72% of people in Munster have a lower level of awareness across the national average. If you just want to take that into a gender perspective, 69% of females feel their awareness or knowledge of Sláintecare is poor or very poor, compared to 62% of males. And across the ages, it's quite similar. So again, those of you that are good at maths, you'll see already that those that say they have a good or very good knowledge of Sláintecare is only 7%. And as I said, this is very, very similar to what it was last year. So in the space of probably maybe 14, 15 months since we ran this survey first time round, it's changed very little, which I think is really, really interesting and in its own right. The next question we ask, do you support one of the key proposals within Sláintecare to remove all private care from the Irish public hospital system and to stop private insurers funding private care in public hospitals? So 62% agree with that statement, that private care and private insurance funding should be removed from public hospitals. We're trying to pull out some interesting statistics. More females than males agree with this, so you can see the difference there. No surprise, those older age groups agree with this statement much more strongly than younger age groups. However, some of the regional perspectives are quite different. Munster comes in at 62% agreeing with that statement, compared to Connacht Ulster, where we have 76% of adults living in Connacht Ulster agreeing with that statement. So we see some quite interesting age, gender, and also regional variances across our research. The next question is, do you think this aspect of Sláintecare is an achievable goal? 46% agree with that. And you see that's lowest amongst those in the 55 plus age group. That drops down to 39%. Those that agree with it more strongly, females at 59%, sorry, apologies. Those that disagree with it more strongly, 59% of females say it's not an achievable goal. The region that feels that it has the highest level of success or the ability to achieve its goal is outside of Dublin, across the rest of Leinster at 58%. So again, we see different, I suppose, belief systems in terms of the success or the ability to deliver on Sláintecare. A key question then we ask as follows. The government says it will take 10 years to implement Sláintecare, but how long do you think it might take to fully implement? And we see here those figures that I think the government had suggested 10 years. So 5 to 10 years, 14%, 10 to 15 years, we see 24%. So they're on the lower edge of the scales. We see the highest group of those that think it can be implemented within 5 to 10 years is that younger age group. So that was really interesting, where again, we continually see maybe a slight disconnect from those younger age groups to what really is going on in the private and public health systems. So they think it is more likely to happen sooner. Those that believe it's going to take a lot longer to implement, only 7% of 55-year-olds believe that it will be implemented within 5 to 10 years. The biggest rump, I suppose you could call it, of where adults believe the time to take to fully implement sláinte care is 15 to 20 years. So 30% of all adults believe it's going to take 15 to 20 years to implement. That's highest in Munster at 39%, believe it's going to take 15 to 20 years, and it's lowest in Dublin and Connacht Ulster at 23%. So again, even those in Munster believe it's going to take that a little bit longer. I suppose the big figures to the far right, 11% believe it's going to take, 11% is going to believe it's going to take 20 years, and 21% believe it's never going to happen. That's highest in Dublin at 25%. So there's a real job of work to really educate and raise awareness of those timetables, or really focus on bringing those timetables to the shortest possible conclusion. We asked, do people have health insurance? 58% said they did. And again, no surprise, highest of those 55 plus, hitting 65%. And we also asked, have they had experience of the private hospital system? 50% of those 58% said they had. That's highest again amongst the 55 plus group, and actually surprisingly high in Connacht Ulster at 63% that had experience of the private healthcare system. We asked how was that experience. So of those that actually experienced the private healthcare system, we asked how was the experience. It was good or very good for 67% of those that experienced it, which is an amazing figure. That jumps to 74% of those that experienced private hospital treatment in Dublin. It jumped to 86% of those over 55 years old. And interestingly, those that are 45 to 55, 75% of those said they had a very good experience of private hospital treatment. So I think those figures are really solid across age. Also, gender is quite similar. There's no real difference in terms of that experience across gender, which I think is always good. 21% said it was okay, and only 12% said they had a poor or very poor experience. The next series of questions, we talk about partnership and the state and private healthcare working in partnership. So this question, I just want to read it out just to put it into context. In your opinion, should healthcare in Ireland be planned and delivered separately by the state and private healthcare providers, or by both sectors working together in partnership? 69% said said they believe it should work in partnership. Only 31% said they should be separate services and separate systems. Interestingly, where we saw Munster being slightly behind in some of their belief in terms of delivery of sláinte care, actually they had a much stronger desire to work in partnership. 75% of adults in Munster said they believe it should be working both in partnership. 76% of females felt the same, and again, consistently we see those older age groups, 45 plus, 55 plus, jumping into the late 70s in terms of agreeing with that statement. The next statement we asked, Ireland will require at least an extra 2,600 new beds as part of sláinte care in the next 15 years to deal with population growth and an ageing population. Do you think the government should try to deliver all 176 beds per year on its own, or should aim to work in partnership with the private system? Again, 69% said they should do it in partnership. That jumps to 74% of adults living in Dublin. It jumps to 77% of those over 45 and over 55. And as you see there, it jumps to 73% of females all saying they wanted to work in partnership. Interestingly, more males slightly believe that the government should go alone. The final question, I think, on partnership. There are over 900,000 people in the country currently on a list awaiting treatment or assessment by a consultant, an increase of 167,000 people since the same time last year. Do you think this list can be tackled by the public system alone or in partnership with the private hospital network? 83% believe it has to be delivered in partnership with the private system, and this jumps to 87% of males. When we ask about those doing it alone, or just focus on the public system alone, 23% of males think it should be public system alone. And interestingly, those aged 18 to 24% think the same. So that's again a huge variance in ages. However, the flip side of that is only 6% of those 55-year-olds plus believe it should be the public system alone. So to summarize, and putting it back into a population figure, when we look at that first stat of only 65% of adults in Ireland having a poor knowledge of sláinte care, that equates to just under 2.5 million adults in Ireland. When we ask about removing private healthcare system from the public system, that 2.35 million adults in Ireland agree with that statement. Is it an achievable goal? Almost 2 million don't believe it's an achievable goal. 800,000 believe it'll never happen, and 1.14 million believe it's going to take between 15 and 20 years to deliver sláinte care. The final question is on partnership. 2.6 million adults in Ireland want healthcare delivery in partnership across the public and private systems. 2.6 million adults believe partnership is required to tackle beds and delivering of new beds in Ireland. And 3.1 million people believe partnership is required to address waiting lists in the current hospital system. So that's my quick run through of the findings from the research. I don't know if anyone wants to ask a question or comment or hand over.
Thanks very much, Oisín. That's very, very informative. And I suppose the really heartening thing for the Private Hospitals Association that I've taken out of that is that the majority of the population want to see a partnership and a shared approach to healthcare in this country. And I think that's what we're about in the Private Hospitals Association, and it echoes what the Minister said this morning, and indeed Liam Woods from the HSE, that we really need to work together and use our joint capacity to actually effect change and to have the healthcare system that we deserve. I guess the little bit, and maybe those in the room and those who are here with us virtually, I was concerned about is that most people believe it's going to be 15 to 20 years if it's going to happen at all, and that is very concerning. And surely we've seen in the last year we can move mountains when we need to in the middle of a pandemic, and let's hope, I think, that 15 to 20 years is not the timeline that we're going to see this new health system for our citizens. So thank you very much for that. Looking forward to distilling that information further, and appreciate your time this morning, Oisín. Thanks a lot. So our session this morning is based on meeting the challenges, and certainly Oisín has outlined for us potentially some of the challenges that we need to overcome in order to get the healthcare system that we all want most fervently. And we heard from Minister Donnelly this morning about the challenges that we're facing currently with the pandemic, and also we spoke about the waiting lists. And indeed our chairman, Bill Maher, has reiterated most firmly that we in the Private Hospitals Association welcome the opportunity to engage with the Department of Health and the HSE. And indeed, this is something that we've sought for many years. And it was good to hear Liam Woods echo that there is a view now in the public system, I think, that we can work together. And we've shown that certainly during the pandemic with the assistance that we gave to the public system. So we here in the Private Hospital Association are fully committed to the single tier system. And as Audrey Deverley observed earlier when she was presenting to us, we have all of the ingredients in Ireland already to make this happen. So let us be ambitious and let us be collaborative and let us embrace and invest in digitisation. And as Brian Turner spoke to us earlier about the ESRI projections for hospital beds that we're going to need, they're only going to increase. So we need to address this collaboratively. The challenges we must meet certainly must focus on physical health care, but we must also focus on the areas that I'm very passionate about myself and which our speakers this morning are going to talk to us about. And we're talking here about parity of esteem between physical and mental health. We're talking about health and well-being in the workplace and generally. And we're also going to be talking about how healthcare big data can help us to meet the challenges of patient care that we're facing. So I'm looking forward very much to hearing each of our speakers this morning. Our first speaker is Dr. Harry Barry, and Dr. Barry is based in Drogheda, has been a GP for over 40 years, and is very much an advocate of talking to people about what is emotional distress, how to manage our anxiety, and how to better have health and well-being in our lives. And I think we've all experienced in the COVID-19 pandemic stress and anxiety and turmoil. And I think it has shown us that mental health has been to the fore in the pandemic, and I suppose the fallout that that has had for the whole of society, not least of which is the healthcare profession, who have been under tremendous pressure. So really looking forward to hearing Harry talk to us this morning, and maybe we can all take away something on a personal perspective from his talk. So you're very welcome, Harry. Thank you.
Thanks very much, Emma, and it's absolutely great to be here this morning. You know, we all talk about mental health, and as I said at a big meeting in London pre-COVID, we're all obsessed about talking about mental health. We're all terrified about talking about mental illness, which is, you know, severe psychosis, severe bipolar disorder, severe treatment-resistant depression, and so on. But what we're not talking about is the elephant in the room that affects us all, and that's the world of emotion distress. So emotion distress is basically caused by a life crisis situation, which COVID is a classic example, plus or minus toxic stress, anxiety, or depression. So what I'd like to do this morning, this talk is really all about how can we recognize some of these conditions in ourselves, and how could we, through a combination of self-care and some emotion resilience skills, really try and improve our mental health and well-being. So I would throw out to all of you listening to me here this morning, who looks after us, the carers? Very important question this morning. We're all struggling. COVID has destroyed the working, personal and community lives of us all in the last 20 months. We're all traumatized, we're exhausted, we're burnt out, we're worrying about the future and what it will bring. And I think in the past 18 months, 20 months, we've all coped with the fear of getting the virus ourselves, passing it on to loved ones, vulnerable ones getting it. We've been struggling with these wave after wave of new variants, the uncertainty, the abnormality of it all, and the sadness of those who've lost loved ones. And I think for those who've working from home, a lot of our admin staff particularly, I think they've felt terribly isolated. They've been struggling with lack of space, lack of structure, struggling with having kids at home at times. Lack of human input is a major thing. And I talked to somebody recently who was really, really struggling with this. I think we've struggled with the whole issue of because we're at home, we're working longer hours, we're using too much technology. And I think obviously those who are working on the front line directly are really in the firing line and are really, really getting burnt out. I think there's also the concerns about the future, which is very uncertain, the conflict between working from home, blended working, working full-time, concerns about issues, what are going to affect us in the future. And I think, let's be blunt about it, those working in the private health system, and in fact in the whole health system, are actually worried about where the hell are we going. I've worked in this system for 40 years, and having worked in the third world myself, I sometimes despair is probably the word, that will we ever get our act together in this country? We've just over 5 million people, and for God's sake, can we not put together a proper physical and mental health systems? I think then we've major issues with resocialization. This is a big issue that's happening at the moment. The strangeness of us all coming back together, as we're going to have to do in the next 3 to 6 months. Fears about working with unknown colleagues, are they vaccinated or not, and there's that lurking under the surface. I think there's all this concern about increased workload with public health measures, and so on and so on and so on. COVID has brought just a mass of problems into our lives. But I think we have other issues then. We have the what I call the real life ones, you know, where we're worried about our finances, worried about relationships, worried about our families, and all of those things that come into our lives. So all of this has the potential to trigger the first of the conditions that I want to deal with this morning, which is toxic stress. And I think all of us who work in the profession and health area are really, really at risk of toxic stress. If it's there for more than 3 months, we call it burnout. Burnout is just a fancy name for toxic stress. So toxic stress occurs when our physical and mental health reserves are simply overrun by the stressors that are going out there in our lives. And the consequences of toxic stress, which we'll talk about in a minute, can be quite severe for all of us at a personal and family level. So what is stress? Stress is simply our body's response to external stressors. And it's very much, I suppose, in the body, organized by 3 critical stress hormones: our adrenaline, our noradrenaline, and our cortisol, particularly our cortisol levels. So how does toxic stress present to us? And how many of us, I can relate to all of these? And if I had an audience in front of me, you can all put up your hand and saying, who has not had the following? Where you're constantly tired, you're not sleeping well, you seem to be kind of not even refreshed by your sleep, maybe very restless, where you're tired and wired all the time, where your cognition, which is your attention, your concentration, your short-term memory, your working memory, your problem solving, and your speed of doing things. I certainly can speak that my cognition has been hurt by this long period. And I think toxic stress also brings on a lot of difficulties with irritable bowel, with things like tension headaches, viral infections, viral ulcers, all those types of stuff. And then we have the psychological impact. How many of us have become really anxious? It's the one word I'm hearing over and over and over again, and any group I talk to, it's the same issue all the time: anxiety. And the 2 big emotions of toxic stress are anxiety and frustration, and we're going to be dealing with those this morning. And then what about our negative behaviors? What the hell do we all do when we get very stressed? Let's be blunt about it. We don't get enough sleep. We surf the net at night. We're on our technology. We're looking at our social media. We're drinking too much. A lot of us during the long lockdowns put on weight. We're eating the wrong foods. We're short with our loved one. We're not exercising enough. And all of us, if we're honest, and put up our hand and say, yes, I can see myself here. And we should be honest enough, because if we don't, we're not going to resolve the issue. So you may say, well, why am I worried about toxic stress at all? Well, I'm a GP for starters. I'm a doctor. And remember that there are consequences from high cortisol levels over long periods of time, including heart attacks, strokes, cancer, and high blood pressure. And I know, for example, of a young person, a young manager who didn't listen to his body and has had a massive stroke and will struggle really for the rest of his life with the consequences of it. So we must listen to our bodies. And psychologically then, there are big issues in relation to the psychological consequences of toxic stress. We can get anxious, we can get depressed, we can self-harm. I've certainly lost a number of colleagues over the last 5 to 7 years from suicide. Alcohol dependency. Do you know what I mean? How many people have gone down the road of misusing alcohol? So the second big group of conditions that cause emotional distress is anxiety. And for God's sake, will we stop using the word anxiety and start using the word instead, which type of anxiety? First, we have normal anxiety, but then if we're struggling with significant anxiety, there are 3 types of anxiety, to make it very, very simple for everybody. First type of anxiety is acute anxiety. That's a panic attack or a phobia. And panic attacks, these bursts of adrenaline where we get shaking, sweating, stomach knots, heart pounding, etc. They are massively endemic in our population, especially among all our young people, and they cause huge amount of worry and concern. And when we start getting the equivalent of panic attacks in certain situations, we develop all these phobias where we get worried that we're going to get exactly the same physical symptoms in different situations. The good news for you is that that can be very, very quickly dealt with by a very simple technique called flooding, if anybody wants to ask me about it later. The second type of anxiety is the world of social anxiety, which is where we get very, very anxious when we go into certain social situations or giving presentations. And the third type of anxiety is general anxiety, and this is the one that's really causing the greatest amount of trouble in our country at this moment in time. So general anxiety is very, very common amongst many women. And it's where we worry about the future. We live in a constant state of worrying, catastrophizing what's going to happen in the future. We're catastrophizing about what's in our heads all the time, very much rating ourselves all the time, which we'll be talking about in a minute, and very much associated with physical symptoms like sleep problems, dental problems because we're grinding our teeth at night, irritable bowel, cognitive problems, procrastination, perfectionism. So those 2 sets of conditions, toxic stress and anxiety, are probably the really big ones that are going on in our community at the moment. But I think it's really important that I nail the one that we don't want to talk about, which is routine, ordinary bouts of clinical depression. And these come, it's really important, they come in bouts of 6 to 9 months. You're not depressed all the time, they just come in bouts. Very much triggered by stress. Could I say to all parents here, please, 50% of all cases of depression will present for the first time between the ages of 15 and 25. 50%. 25% between 15 and 18, and 25% between 18 and 25. So a lot of our young kids who get very stressed, particularly exam situations with COVID and all the rest of it, it can trigger a bout of depression. So it's really important that we identify them because we normally miss them. So the depression, I think it's important that it can affect up to 10 to 50% of our population. And I think it's really important that we quickly go through the symptoms. You may feel very, very flat down for weeks and months. You don't want to get out of bed in the morning. You have no energy of any kind. You stop enjoying life. You're totally demotivated. You may find your thinking becomes totally negative. You can see kind of very little hope for yourself in the future. You believe that you're of no value to yourself. You believe this horrible word that I have no worth, that I'm worthless. And really the one I'm very interested in is, and it's very important for everybody listening to be in the workplace, that it is a huge problem with cognition. And it's one of the most unrecognized problems, as far as I'm concerned, one of the major causes of absenteeism and presenteeism at work. Because up to 95% of people with depression will have some form of cognitive difficulties. And I worked with a world group for a while, and it was very interesting, and I learned a lot about it. And for me, it's something that we just don't talk about it. So cognition is, I can't pay attention to something. I can't concentrate. I look at my phone and I'm not integrating the messages. I'm a student and I'm reading and I'm not integrating the information. My short-term memory is gone. My working memory is gone. My speed of doing things is gone. My problem solving is gone. So I'm struggling to work, and yet I feel I have to keep going, and yet I'm feeling terrible. And of course, all of that leads to thought of eventually of where I become absolutely in my head, I can't go on any longer, and I get thoughts of self-harm. And a really important question, if anybody here has anyone close to them who they feel is not in a good place, please ask the question, have you thought of harming yourself? Because it's the one important question we all need to ask. It's common in depression to have it, but it's the next question that really matters. What would you do if have you thought about what you would do? And the person who gives you a clear plan I'm looking at that rope in the garage, I'm walking up and down by the river, I'm building up tablets, men were talking about wanting to turn the wheel. That's like a cardiac emergency. That person is really in trouble and they really need help. Right, so there are three common conditions. So how can we reduce the chances of getting these? Toxic stress, anxiety and depression. So I'm going to go down the road now of self-care and then some emotion resilience exercises. Self-care is the part that everybody wants to go off and make a cup of coffee. Sure, I know all this stuff. Self-care is lifestyle, but how you live your life is dependent on how well you listen to the next part of what I'm going to talk about. Because the first thing we have to do, we have to look at what are the chief lifestyle things that we all have to change. And the first one, believe it or not, is sleep. Everybody assumes that it's going to be exercise, but it's not. It's actually sleep. Because sleep, we all need, whether we like it or not, 8 hours sleep. And our young people need 9.5 hours sleep. So let's look at this logically. Why do I need sleep so much? Because sleep can be divided very, very quickly into two groups of your 8 hours. The first 4 hours, it's your body's, your brain's chance to heal itself, to kind of put itself to sleep, clear all the toxic metabolites out through your lymphatic system, so your chances of dementia begin to reduce, begins to bring down your blood pressure, your heart, gives your heart a rest, has your natural killer cells wandering around the body, killing off cancer cells like breast cancer cells. If you don't get that 4 hours sleep, then you miss a lot of that, and you put yourself at great risk of physical and cognitive difficulties. The second 4 hours from the mental health point of view is really important. You don't get the second 4 hours. Anxiety, depression, stress, and misuse alcohol. So, sleep hygiene is obviously very, very important. So the first thing is turn off the damn devices in your room. Clear your room. Your room is meant to be a place you sleep, not an airline cockpit. Well-aired room, blackout blinds, hot bath before you go to bed, no coffee after 12 in the day. Very important for lots and lots of people. And we all know what to do, but do we actually do it? Go to bed at a proper time. Make sure that you put away all devices 1 or 2 hours before you go to sleep. Second big one is exercise. We all know we need to exercise 30 minutes of brisk exercise every day, but do we actually do it? It's all very well to talk about it and all the benefits, and we all know the benefits of it, but get out there and do it. There's no such thing as bad weather, just bad weather gear. We all know similarly in relation to diet. I don't have to tell you all what to do. Cut out all the sugar out of your diet particularly. Seriously look at increasing your vegetables, your fruit, lean meat, fish, chicken, vegetables. We all know what to do, but it's the cutting out of the rubbish out of our diet and the amounts that we eat and when we eat. Third one is alcohol. Alcohol, whether we like it or not, is the elephant in the room. We all drink too much. And the more we get stressed, the more we want to drink. And it's that first glass of wine, that second glass of wine, and it's Monday, and it's Tuesday, and it's Wednesday. So really important, cut out alcohol completely Monday to Friday is my advice. Out alcohol Monday to Friday. And then just drink with your meals, if possible, with your family. And if you do that, you'll find your levels of alcohol reduce, and that will have a massive impact on your mental health. I think the critical one now is to briefly talk about technology, because technology is ruining our lives. It's really important, it's helped us during this time, but it's destroying our lives. So the next question I want to ask everybody, are you in charge of your smartphone, or is your smartphone in charge of you? Because that's going to decide, to be honest, your mental health and the mental health of your children. So try, for example, and get rid of devices out of bedrooms. Your children should not be having their bedrooms full of devices. I think we should all have definite phone-free device intervals and days where the phone is turned off or put on silent. All meals should be phone-free. All technology should be switched off in every house at 10:30 at night, and that includes us all, the whole lot of us. If exercise or reading, turn off your phone. If you're out for a walk, turn off your phone. Reduce and have free days from checking your social media platforms. Put clear limits on the amount of aimless browsing you do, particularly late at night. If we did that, if we really got on top of social media and technology, the levels of stress and anxiety in our world would rapidly reduce. And I think it's something that we need to all have a long conversation about. Now I want to talk about the world of emotion resilience. Emotion resilience is our ability to cope with the slings and arrows of life. And I'm a passionate fan of emotion resilience. I want us all to learn it, and I want our children to learn it. So these are really simple skills. These are the ordinary, simple, practical skills, and I'm going to do a few of them with you this morning. So the first one I'm going to do is the work-life balance. So I'm going to read out 6 items that everybody here and everybody at home, what I want you to do is, I want you to write down these 6 items, and then I want you to put them in order of importance in your life at this moment in time. And this is not something you cheat, by the way. This is something you do honestly. So I'm going to read out these 6 items in no particular order. Children, wider family, work, hobbies, self, and personal relationship. So children, wider family, work, hobbies, self, personal relationship, and okay, so there should be six items there. 1, 2, 3, 4. Children, wider family, work, hobbies, self, and personal relationship. So what I want you to do, I want you to put them in order of importance in your life at this moment in time. This, by the way, might be the most important thing you do today. This will be what decides how much stress you have in your lives. The person who will present the following type list is usually in trouble. And that would start with children, work, wider family, maybe hobbies, personal relationship, and self. Or another common one is work, maybe children, then maybe hobbies, then maybe wider family, then maybe personal relationship, and then self. So everybody, if they're honest, will probably find that their list is not right. So the correct list, the way it should be in our lives, is as follows: self, personal relationship, children, wider family, work, and the rest, which is hobbies, etc. So you may say, well, why is it like that? Well, if we don't look after our personal, physical, and mental health, we're of no value to anybody else. Secondly, if you are lucky enough to have somebody you love in your life, guard that with your life. Put your hands and arms around that personal relationship. That's the most important thing in your life after your own personal self. If you have your personal self and your personal relationship, if you're looking after those, it's like building a house on solid foundations. Now you have something solid to work on. Your children should be on top of that. Children should be part of the house, not the house. Then wider family, like, say, elderly sibling or elderly parents or whatever, or siblings in trouble. Then work, and then the rest. So I suggest to everybody here and everybody listening to me that maybe for the next 3 months, if you really want to change your life, and I've had people come back to me and say, this exercise has changed your life. Pre-COVID, I remember one of my colleagues gave me a big, big hug because I gave this talk to a group of my own colleagues, and they were very affected by it. And this girl came up and gave me a hug and said, it was lovely to get a hug. What am I getting a hug for? She said, because this exercise changed my life. So I want you to, together with your partner, if you have a partner, every week, once a week, I want you to write down, each of you, what was your personal priority list for that week? And did you get it all wrong? And what are you going to do the following week to try to improve it? And bit by bit by bit, you'll notice that you get it closer and closer and closer to the way you want it. And over time, you notice that you're not as stressed, you're not as anxious, that you're coping better, your children are happier, your relationship is better. Get it wrong, and you're looking at all kinds of bad consequences, because stress is inevitable, because you've got all your priorities all wrong. Second thing I'd like to talk about is the world of control. Why do we get anxious? And why are all our children anxious? And why are we all anxious? Because we have no control over what's going on in our lives at this moment in time. Because at the heart of anxiety is the world of control. And at the heart of control is the world of uncertainty. And what are we facing? What have we faced in the last 2 years? The most extraordinary amount of uncertainty. What are you all facing going into the future? Uncertainty. So here's a wonderful exercise for people who get anxious or frustrated. We'll talk about frustration now in a minute. I want you to list off 10 items that you love to do in your everyday life. Let's say you go for a walk, you do your yoga, you do your Pilates, you like reading, you like music, you like cooking, you like going out for a meal with your partner, whatever particular things you personally love to do every day. And what I want you to do now is I want you to make a deal with me that for 4 weeks you'll do the following exercise. I guarantee you very few of you will get beyond a week. Because this exercise really packs a punch. Because you're going to get a coin, and on one side of the coin is heads, and the other side of the coin is tails. And heads means yes, and tails means no. So it's a 50-50 chance. So what I want you to do is, every time you want to watch something on Netflix, every episode of every series, every bit of TV, every sport, everything you want to watch, you have to toss a coin. Heads I can watch it, tails I can't, and I'm not allowed to watch and repeat. Heads I can go out with my partner for a meal, get ready, get dressed, organise, going out the door, toss the coin. Heads I can go, tails I can't. I'd like to see you cope with that one. Heads I can walk as fast as I like, tails I have to walk like a snail. Heads I can read today, tails I can't. Heads I cook something I like, tails I cook something I hate. Heads I listen to music I like, tails I listen to music I hate. And of course, what this does, it teaches us that life is like the toss of a coin. But because the chances of you, say, seeing your episode of something on Netflix is 50-50. Whereas in real life, the chances are stacked way much better in your favor. But in life, there is always a percentage chance that something will happen. So it's teaching people to take control away from. The reason we think we control big things is because we think we can control our everyday lives. So when we break up our everyday lives and realize, geez, I can't control anything. Welcome to the real world. That's what real life is actually about. It's teaching us how to cope with that. And if you've got an anxious child at home, get them to toss the coin. They'll really love it. They'll love seeing you suffer. And, it's a fantastic exercise to get it across. If you're a catastrophizer, lots of people catastrophize, do you know what I mean? Because they spend their whole lives thinking about what might happen in the future. A very simple exercise there for 4 weeks. Write down what are you catastrophizing about, and ask yourself, it's like spilt milk. Is it a drop of spilt milk, or is it a puddle? And where's your evidence that something is definitely going to happen, or is it actually only a drop or a possibility? Because what we do in our emotional mind is stronger than our rational mind. So when it's going on in our emotional mind, it goes on in a cascade. When we write it down, we see it with our rational mind, we suddenly realize, hey, there's no chance of that happening. So you begin to kind of get it back in order. I have to go through some of these fairly quickly now. Empathy is really, really important for me. If I was to pick 2 skills out of everything I do today, it would probably be empathy and the world of unconditional self-acceptance. So very quickly, empathy is the ability to sense where another person's at from an emotional point of view. And if employers want to do something really practical, start practicing empathy in your whole workplace. Let empathy be. Empathy is how we sense where another person's at. You go down to your local supermarket, you meet this girl who's lovely and bright and chirpy with you and helps you and you go away with a lovely feeling. The following week you're in and you meet her alter ego, Mrs. Grumps, and she fires everything, she scowls at you, and you come away feeling very disgruntled. That's the way we all are when we meet colleagues, for example, who are warm and empathetic and want to share where you're at, and other people who just want you to get out of their lives and just get on with it and do your job. And so really, really important that empathy is a critical skill. Spend 6 weeks in your life studying the effects of positive and negative empathy in your everyday life, in your workplace, in your social life, and then spend 6 weeks trying to sense where the other person's at from an emotional point of view. There's another thing called cognitive empathy, if anybody wants to ask me about that one later. But empathy is something critically important. We all need to start learning it and practicing it. I want to talk about the world of self-rating. The biggest problem we have in life, and the reason that we're all struggling so much, so many people I've had to say this to, it is a situation that's abnormal at the moment, not us. But what are we all doing? We're all rating ourselves. We live in a world of rating. So here's a lovely exercise for you. I want you to draw a line and at one end put 1 and one end put 100. 1 means that you're crap and 100 means that you're fantastic. And I want you to rate yourself as a person between 1 and 100. This is your chance. You know, but just to let you know, the ones that I struggle most with are the ones between 95 and 100. God spare me from the high raters, the perfectionists, the ones who can never get it wrong. But so then, where do other people rate you between 1 and 100? There's a very interesting one. Where do we believe other people rate us? And of course, it's an incredible thing to do because it tells us so much about ourselves. Do we rate ourselves down all the time? Do we rate ourselves up all the time? Are we more worried about what other people think about us? And our children play this rating game all day long, and we play this rating game all day long. Now, suppose I asked you a few simple questions. You make a mistake at work. Where do you rate yourself then? And where would other people rate you? Somebody tells you you're a bad parent. Where do you rate yourself then? And where would other people rate you? You're diagnosed with depression and put on medication. Where would you rate yourself and where would other people rate you? And of course, all of these things are critically important because what do? We go up and down this rating scale. If things are going well, we rate ourselves up. If things are going badly, we rate ourselves down. But of course, the secret to this is, as the father of CBT, Albert Ellis, very quickly realized, you know, can we rate human beings at all? No, of course we can't. Every person listening to me here is a beautiful, special, unique human being. There is nobody like you in the world, and there never will be like you, another person like you in the world. So we cannot rate one person over the other. If you don't believe me, if you have children, stick them on the couch tonight and rate one over the other. And very quickly you say, but how can I rate Mary over Jerry? Because they're absolutely different, and of course they are. And we're all absolutely different. But this is the game we play. Because what we actually do in mental health terms, we merge who we are with what we do. And if we're successful or fail at what we do, we think we're either great or we're a failure. And of course, our young people are falling into this trap because they're using social media. And if social media is all about the world of success, so they believe stupidly that people can be successes rather than that people can be successful at something or people can fail at something. And this is probably the most important message you'll come away with today. Because if you can realize, look, we're all human beings, we all mess up in our behavior. So we can't be rated as individuals, but we can certainly be rated in terms of our behavior, our actions. So remember that for the rest of your life. I can fail at a task at a particular moment in time, but I can never be a failure as a person, as a human being. And we all have this internal critic that constantly gets us to believe that we can. I'd like to do just one final 3 questions on low frustration tolerance. I said one time on the Claire Byrne show that the greatest hidden emotion in the whole of mental health, and the one we don't want to talk about and yet is causing chaos, is frustration. And the 2 big emotions that I'm seeing in my society at this moment in time, this country I love, is anxiety on the one hand, frustration on the other. So the battlegrounds are being drawn between anxiety and frustration. So what is frustration? Well, frustration is actually, we call it disturbance anxiety or discomfort anxiety. It's where we want the world to be a certain kind of way. And I can pick out the people instantly in a work situation whose natural response to something is to get frustrated. And the trick behind frustration, low frustration tolerance, I want long-term gain, but I don't want any short-term pain. I don't want any hassle. I don't want any discomfort. I want the situation and people and the world to change, but not me. In other words, I want everything else to change, but I don't want to change. And of course, if I live in that world, then I'm irritable and bad-tempered and difficult to be with and often lack empathy. And of course, I cause lots of difficulties for my fellow colleagues. So I had a very successful businessman came to me, and he thought he was anxious, but actually he was suffering from frustration. And I gave him the following exercise, and 3 months later he came back to tell me that his whole life had been totally transformed. His home life had been transformed, his working life had been transformed. So we have to be honest with ourselves. If we identify this in ourselves, every time you're frustrated for the next 2 months, I want you to write it in a notebook, and I want you to answer the following 3 questions. Question number 1. What is my long-term goal in this particular situation? What is my long-term goal in this particular situation? Number 2, what short-term pain am I trying to avoid in this situation? What short-term pain am I trying to avoid in this situation? And the 3rd one is, what changes in my thinking and behavior do I need to make to achieve my objective in this situation? What changes in my thinking and behavior do I need to make to achieve my objectives in this situation? And if you can answer those 3 questions every time you're frustrated, and stop being irritable and bad-tempered and short and demanding the world changes to suit you, what will happen very, very quickly is you'll begin to realize that it's me that has to make the changes. It's me that has to kind of accept the discomfort. That if I want a long-term objective, for example, suppose I want a person at work and I'm frustrated that they're not doing something, well, maybe I need to sit down with the short-term discomfort and work with that person in a nice, pleasant, empathetic way to help them understand what you're looking for. You'll get your long-term objectives. They'll feel much better about the situation. You won't be frustrated. And by the way, frustration leads to a lot of toxic stress, leads to your heart attacks, your arrhythmias, etc. So listen to the world of frustration. And it's also a key thing in the workplace. Empathy and LFT are huge problems in the workplace. So we might discuss mindfulness maybe in a minute, but I just want to finish with that. That's just one of about 20 different skills I laid out in a book called Emotional Resilience. And I think lots and lots and lots of us could so benefit, not in our own lives, in our family lives, in our working lives, and in our community, and we should be teaching our children all these particular skills, because the lifestyle and emotional resilience skills are how we're going to get our way out of all this. It's how we're going to reduce our stress, reduce our anxiety, reduce our frustration, and try and reduce our chances of depression. So thank you so much for listening to me this morning, and I'll hand you back to Emma.
Thanks very much, Harry. That was most informative, I think we'll agree, and certainly there's plenty of tips there, I think, for all of us. I'm trying to figure out how I'm going to get the technology out of the teenagers' hands in the evening. I suppose that's my biggest challenge when I go home, but I think you're right, Harry, certainly technology in our personal lives, we can certainly take more breaks from it, I think. So thank you for that, Harry, and if you wouldn't mind taking a seat, and we'll have our questions and answer sessions afterwards. Thanks so much. And I'm now delighted to introduce our next speaker, Fiona Coyle. Fiona is the Chief Executive of Mental Health Reform. And before that post, Fiona was the International Advocacy Manager at the IPPF European Network. And there, Fiona led the Federation's engagement with the European institutions. Fiona has previously been the Network Coordinator for Euro NGOs and a Programme Manager with DOCUS, which is the Irish National Platform of Development NGOs, where Fiona managed policy and programme coordination across the network of 65 NGOs and other civil stakeholders. And Fiona's going to talk to us this morning about an area, as I said earlier, that I'm particularly passionate about, and it's about the parity of esteem between mental health and physical health. So over to you, Fiona. Thank you.
Thank you so much, and delighted to be here this morning to discuss around mental health. It's very strange actually to be in person at a presentation rather than at home wearing my slippers, but I think we've all taken comfort over these digital presentations over the last 18 months. So my name, as you know, is Fiona Coyle. I'm the CEO of Mental Health Reform. So very briefly, perhaps, who is Mental Health Reform? So Mental Health Reform is a membership-based organisation. Here are some of the logos of our members. Some of them may be familiar to you, some more familiar logos coming up there. So we're the national platform for mental health. We bring our 77 members together. All of them, I suppose, believe in one common overarching goal, which is that every individual in Ireland can access the supports and services that they need when they need them to achieve their best possible mental health. So our organisations represent a diversity of, I suppose, sectors. Some are mental health providers themselves, others work perhaps with specific groups such as ethnic minorities or children. But what we do as Mental Health Reform is we provide a platform similar to the Private Hospitals Association for our members to come together. At the heart of everything we do is the voice of service users and their family, friends, carers and supporters. So we have a grassroots forum that informs all of our policy submission and kind of our overall work. We do a lot of public campaigning. Some of you may have seen work we've done around 24/7 crisis mental health care for children and young people, or more recently around the budget. We also, and especially over the last 2 years, have been working on the area of innovation and e-mental health. Today in my presentation, I'm going to cover, I suppose, 3 broad areas. Firstly, I want to take a look back and look at Ireland's mental health journey, then look at perhaps the current day. There's a lot of changes ongoing in both policy and legislation, and then look to the future. You know, what have we learned over the last 2 years or perhaps the last decade, and how can we move towards that parity of esteem between our physical and our mental health? I came across an article earlier this week. It wasn't in relation to Ireland. I think it was in relation to mental health in the US, but it used the headline, "Mental Health, the Cinderella of the Healthcare System." And it's one that often comes up in Ireland, and it's used by many. You know, we're part of the family. You know, it's broadly recognised mental health as a key component of, you know, our general population's health. But, you know, underfunded, a bit neglected, still hasn't quite perhaps met the Prince or Princess Charming to really bring it to the level that it deserves. But I think it's really important for us to kind of reflect back a little bit on our journey as Ireland with mental health, and why mental health has been and continues to be the Cinderella of the healthcare service. So in 1961, the WHO stated that Ireland had the highest rate of institutionalisation of anywhere in the world. 1961, that's not that long ago. That's my parents' generation, and that's very real and very raw for a lot of people still in Ireland. So while we've progressed and broken down a lot of stigma, we have to understand that there's still a lot of underlying stigma towards how people with mental health difficulties were viewed and were treated by the state. It was only in 1984 that community services began developing with the launch of Planning for the Future report. And then in 2006, there was the launch of the landmark policy, Vision for Change. This policy was hugely welcomed. It was seen as transformational. It looked at building our community services, giving people the support that they need in their communities so that we could move away from the institutional model that had been in place previously. Then Ireland went into one of its greatest economic recessions, and a policy document that needed more funding, more support, you know, to build these really key community mental health services. Actually, what we've seen, like all sectors, was cuts. And I think it's fair to say, you know, we haven't quite got back to the same levels of investment that was there pre-2006. But I suppose, you know, the good news is, in a way, is that there is and there has been a lot of changes over the last 2 years. And it's a whole new landscape. So last year, in June, in the midst of the first wave of the pandemic, the government launched Sharing the Vision, Ireland's new mental health policy. I'll get to a bit more of the details in my next slide, but I think it's important to note this was one of very few policy documents that was launched during that period last year. And, you know, as Mental Health Reform, we like to view that as, you know, a significant acknowledgement that, you know, at the time it was seen that COVID would have an impact on people's mental health and well-being. But apart from the policy, the whole legislative environment is also changing. Ireland's Mental Health Act has been long out of sync with international human rights standards and various conventions. And earlier this year, the Department of Health published its new heads of bill for an updated Mental Health Act, and that's currently undergoing pre-legislative scrutiny. Long time ago now, in 2015, we also seen the Assisted Decision Making Act was passed, but unfortunately that still hasn't been implemented, and the enactment of the Decision Support Services, fingers crossed, will happen in June next year. But I suppose what's important about this act, it's really looking at how we view perhaps people with mental health difficulties, psychosocial disabilities or broader disabilities, and looking at how we can maximise people's ability to make decisions. So, you know, we moved away from, with the assisted decision making, from looking at kind of someone's capacity is not having it, to what can we do to support people to communicate their will and preference, and how can we put supports and systems in place to help people who may have difficulties in taking decisions. Then finally, it was really wonderful listening to Dr. Harry Barry's presentation just before me, and I think over the last 2 years, you know, the prominence of the mental health aspect of the public health crisis that is COVID has been really real. You know, there hasn't been an address by our Taoiseach, both Taoiseach Micheál Martin and Leo Varadkar before him, that didn't speak or reference the mental health aspects of the pandemic. Prime Time in the last year also carried out a national survey that they called the New Normal, and that looked, I suppose, the next normal, apologies, to better understand the experiences, views and attitudes of people of Ireland during the pandemic. And in that survey, mental health came out as the 4th most important issue facing Ireland at the moment. COVID was number 1, the economy was number 2, and the broader health service was number 3. Now, mental health never featured in any of these surveys previously. So the public, you know, the media, you know, we're really starting to view the importance of mental health. You know, very often, and it's back to those early days, 1940s, 1950s, 60s, where, you know, mental health was very much viewed as perhaps an individual issue. But what we've all realised over the last 2 years, you know, our mental health can be impacted, and people's mental health is impacted by, you know, the circumstances they may find themselves born into, or, you know, different things that happen during their lifetime. And it's something that we all need to take very seriously. So just very quickly, in case of interest, you know, sharing the vision, a new mental health policy for everyone, you know, where are we going with it? I think the principles are really important. It's all about kind of recovery, trauma-informed, human rights focused, valuing and learning. It looks at a whole of population approach and to deliver a range of integrated activities to promote positive mental health in the community. Intervene when early, huge focus on prevention, and then also looking at, you know, the lives of people living with mental health difficulties. How can we promote recovery, and how can we ensure inclusion in society for those who have perhaps more complex mental health difficulties? So you're looking at issues such as housing, such as employment. And also, very importantly, I think for us all, is the real acknowledgement of a person-centred approach. Everyone's journey in this life is individual and unique. Everyone's mental health journey is unique, and everyone's recovery path is therefore unique, and it's all about working in partnership. I think that's a word that's been used an awful lot today. It's partnership between the service providers and the service users, their family, friends, carers and supporters, to facilitate that recovery journey, the reintegration through the provisions of accessible, comprehensive and community-based mental health services. So it's potentially a really transformative document. Word of warning, Ireland does great policies, great documents. Implementation, we do struggle with. So, the truth of this document will be in 9 years' time when we're reviewing it. Just to talk a little bit maybe about COVID and the experience that we've all gone through over the last 18 months or more. It's very much acknowledged, the WHO and others acknowledge, it's a quote from a report last year, the isolation, fear, uncertainty, the economic turmoil could cause psychological distress, and we could see an upsurge in the severity of mental health illness among those children, young people and healthcare workers. Now, we're still in the midst of a pandemic and the data is still very much emerging, so we don't have the full picture. I was struck this morning on my way here, there was an article in the Irish Medical Times looking at the impact of COVID on mental health, and it in particular looked at different studies from around the world, I think China, Spain, also data from Ireland, and there is some trends that we can pick up from the available data that's there. So children and young people, they seem to be kind of more severely impacted, and there's also kind of a bit of a gender lens there as well, that women seem to be perhaps more impacted. But again, all this data is very preliminary and still coming out. But in Ireland, there was some kind of initial studies that was done. So the College of Psychiatrists did a member survey during the first lockdown, and they kind of found that out of their 195 psychiatrists that were surveyed, 79% reported an increase in referrals for general anxiety, and 72% reported an increase in health anxiety, and 54% increase in referrals dealing with panic, and 57% increase in referrals for depression. We also know from the HSE that there have been higher kind of referrals in psychiatry of later life, for example. In mental health reform, one of the big pieces of work that we've done over the last year is a project entitled Brave New Connections. So what we've been doing is looking at the impact of COVID on our members and how our members have adapted during this time. Our members, many of whom would have been delivering face-to-face services over the course of one weekend. Some of them went virtual, then they went back to hybrid, and now it's kind of finding that type of hybrid model and looking at, new e-mental health initiatives. But some of the data that came out that I thought might be interesting for this conference is there is a change being noted in the profile of user groups. So increase for demand, all of our members are reporting an increase in demand for their services. There's an increase in mental health difficulties. Broader geographical reach, so some of their members are now, I suppose, finding people coming to their support groups, those who run them, from across Ireland. So, there's some positives as well, like people from Northwest Donegal, where I'm from, may be able to join support groups in Dublin or Cork. Younger people, a lot of our members have seen a change in their age profile, where there's a lot more younger people seeking support, different patterns of user engagement engagement. For example, the Samaritans last year during the initial lockdown, while they didn't report more calls, the length of their calls grew significantly. I think it was 3 times what was there pre-COVID. So there's these different patterns. And of course, then there's a whole group of society that have been neglected during this last 18 months. The digital divide, it's real. Zoom is expensive. You know, I had someone tell me, do you know how much data Zoom eats up if you're on a pay-as-you-go? And I think we need to acknowledge that as well. A lot of us are very privileged to be in contracts or endless data, but many, many people aren't, and it's been really tough economically for a lot of people as well. But yeah, so more, this is the full report is available on our website. But just to conclude, I suppose, there's no going back from my perspective and from our members' perspective. You know, it's a once-in-a-decade opportunity for mental health to be so prominent in public discourse, having been perhaps neglected for a long time. We really need to use this opportunity. Before COVID, our mental health services and supports were at breaking point, I think it's fair to say. You know, pre-COVID, we'd nearly 10,000 people waiting for primary care psychology appointments. You know, nearly 2,000 children and adolescents were waiting for CAMHS appointments. We can't go back to that. We need to see how we can move forward and take that general recognition now that's there of parity of esteem. You know, so often we hear there's no health without mental health, but then what? What are we doing to ensure that? What does that look like? We really need to address and tackle this question. And mental health, it does need to be placed at the centre of our COVID recovery plans. And we need to build a responsive mental health service which will be really critical on how our society rebuilds and emerges from this pandemic. And to achieve that, we all need to recognise the importance of parity esteem and ensure we're making our voices loud and often heard. But Gurmila Mahigavalik.
Thank you so much. I'll ask you to take a seat there. So thanks very much, Fiona, and we're going to take up that challenge certainly in the Private Hospitals Association as well, for sure. And isn't it interesting when Dr. Harry Barry was talking to us earlier about the physical effects that our mental health can have in terms of cardiac events, in terms of cancer and all of those things. It's really important that we pay attention on a system-wide basis and a societal basis that mental health and physical health are not different. They're not disconnected. They're all part of the whole person, and we need to treat and help and support the whole person. And it is a shame, in my view, that we have a Sláinte Care document and a Sharing the Vision document, and we don't have a joined up document in terms of health, because we can't separate mental and physical health. However, we're going to talk about a way that potentially we can coordinate our health service a little bit better, and I'm delighted to introduce our next speaker to you. So Ahmed Al-Arami. Ahmed is the former Director of Operations at a private hospital, so you're well aware of the challenges that we experience, Ahmed. And you joined Metodica having been a client of theirs, and you enjoyed a highly successful software implementation with them when you were working in the private healthcare industry. Ahmed holds a Bachelor of Engineering and has a background in business and has a keen interest in using your skill set to optimise processes, increasing outputs and cutting costs, which we all like to hear for clients, and utilising the best software solutions available to us to meet our business objectives. So you've seen the difference, and you're going to talk to us today that data and technology can make in private healthcare and allowing us to provide more time for patient care. And he's passionate about helping clients to achieve this and understands the importance of data for board members to help steer the private hospitals, and indeed I would suggest the rest of the healthcare system, to a sustainable, resilient and profitable and most of all reliable system. So delighted to have you speak with us this morning and to tell us a little bit more about how big data can help us in healthcare. Thank you.
Thank you. So, good morning everyone, or we're probably afternoon at this stage. Just going to talk a little bit about big data and how it can help us with the challenges we're currently seeing in the healthcare system, which have only just been highlighted by COVID, to be honest. So we'll start by seeing if healthcare big data can help us meet the challenges of patient care. And we know we have a shortage of beds. We know we have a shortage of staff. Even if we did get those beds in place, the staff are not there to cover it. So can healthcare big data, if we had all the data on healthcare, which we've seen time and time again, the data can not be real time, it can be a bit short, we're not covered in all the areas. If we were to get all the data, what would it look like? So I'm not going to reinvent the wheel. Deloitte did a very good animation, and the key thing I want you to remember here is this was done 1 year before the pandemic. And they spoke about this happening over the next 20 years. And I think the pandemic has highlighted that it needs to happen yesterday in order for us to have effective hospital systems for both public and private sector. So what will it look like?
This is Maria and her partner, Ruben. Before their day even starts, they are providing a detailed snapshot of their health and wellness to their network. Maria slept great, but Ruben, who has a history of depression and anxiety, tossed and turned all night. Data from his neuroendocrine system shows a spike in cortisol. That may be a sign that he could be headed for a significant depressive episode. So, before he's even awake, his network has placed time in his busy schedule that day to talk with a virtual therapist about ways to reduce his stress. 20 years from now, radically interoperable data and open and secure platforms will allow consumers to own their own journey of health, providing them with a holistic, real-time view of themselves and their environment. A system in which personalized experiences that are highly tailored to one's preferences and needs are the norm, not the exception, and where care and services can be accessed quickly and seamlessly. Consumers are increasingly willing to share their personal data through wearable technology, smart appliances in the home, and even with the home itself. This vast pool of data forms the basis of their personal health profiles, so that changes or deviations can be detected and addressed immediately. This information empowers consumers to take control of their well-being in ways that were impossible in the past, whether it's proactively heading off depressive episodes for Ruben, or getting Maria her time-released antihistamine well ahead of a high pollen day. This data also provides her to glean novel insights into the health of entire communities and to enable research and scientific breakthroughs at a rate that will only increase exponentially as technology continues to evolve and to integrate into our daily lives. Tailoring care individually based on ever-advancing capabilities to capture, interpret, and act on near-perfect data in real time is a radical change. This change will require a complete rebuild of today's healthcare system and the collaboration of several actors, some old and many new. Those with deep roots in care delivery must ask themselves how they can use data and technology to transform what well-being and care delivery means. Players in the health ecosystem will include non-traditional ones. For example, those focused on the data platforms and tools that enable this new model of health. And regulators, financiers, and intermediaries will all play a new role in this new vision. Disruptive thinking and a commitment to emerging technology are more important than ever before, because the future isn't as far off as it seems. In fact, it's at your very fingertips.
So we can see briefly there the vision of the digital hospital in the future that Deloitte is painting and how healthcare big data is going to help us. So I'm going to talk a little bit about big data and what is big data, and there's a difference between data and big data. And big data is it's available in extremely large volume. It's moving at high velocity. It's highly variable in structure, and these are known as the 3 V's of big data. So unless you're collecting real-time big data, you're not at the forefront of tackling the problems and identifying trends and analysing potential problems that you don't know exist in your hospital or healthcare environment. Sources of healthcare big data, it's quite obvious from the video we just watched, but you have smartphones, wearable devices, generic databases, electronic health records, and these all come together as big data in healthcare. They come from multiple sources, and the ability to pull all that data together into one system and review and analyse is what's going to be key to get ahead of any of the problems we have in the healthcare sector at the moment. So, how do we get there? And Methodica has been around for nearly 30 years at this stage, and as part of a Carasent company, that it is essential that, first of all, this change comes from senior management, that they understand the importance of a digital future and drive support for its implementation at all organizational levels. It's key that there are people who are used to doing things a certain way. It's key that we understand that using pen and paper as opposed to entering that data digitally so it's available for somebody else to see it in real time is I would even go so far as to say risking people's lives, depending on the situation, if it's acute. I mean, if we were to look at a situation where we could actually get an ambulance providing real-time data with an acute patient situation to a hospital before it even arrives at the hospital, and there's a doctor monitoring this patient that's coming in before he's even arrived at the hospital. So it's key that we accept that technology is now part of the healthcare sector, and it's a big part of the healthcare sector. And we talk about recruitment going forward, and we need to prepare for talent 2.0, as we call it. As hospitals invest in exponential technologies, they should provide employees ample opportunities to develop corresponding digital skills. An augmented workforce and use of new technology requires current staff to learn new skills and to manage and work alongside the artificial intelligence processes that are available. How do we bring in patients that we're monitoring in real time? How do we send home patients that have just had surgery and monitor them from home? Can we create more bed space by doing this? So it requires a whole new way of thinking in order to optimize the healthcare industry. The system that you have in place is built on big data fundamentally. While the requirements of data interoperability, scalability, productivity, and flexibility are important, they should be built upon a solid foundation of capturing, storing, securing, and analyzing data, and particularly in real time. Organizations should create a strong system-wide data infrastructure, whether that's clicking in the time the patient arrives, whether that's giving the patient access to patient portals so they can fill out their forms at home, so we can see that this patient is not suitable for an elective surgery and cancel that surgery before they even come to hospital and take valuable time in a consultation with a doctor, which we know have limited resources of in today's healthcare industry. Another problem that we need to overcome is we need to understand that we're playing the long game here. Since digital technologies are ever evolving, flexibility and scalability during implementation can be critical. Planning when you're implementing for future projects is key as well, because technology is ever evolving. So the planning team should confirm the project scope includes adding, modifying, or replacing technology at lower costs in the future. I'm going to talk a little bit as well about investing in these systems and whether the time is right, and whether, should we focus on what's in front of us right now, which is the pandemic. And yes, obviously, acute care is what's at the forefront of every private hospital, and assisting the public situation at the moment is key. But I think, given the return of investment that you will get from fully digitizing patient care and being able to deliver value-based patient care by using big data to your advantage, I think this investment needs to happen sooner rather than later. And it's not to be viewed as a cost. It's to be viewed as something that you are investing in and you will get a return on investment from. So what is the ROI of a digitized hospital? Digitized operations, number one. Many back office functions, finance, supply chain, human resources, revenue cycle, among them can benefit from advanced analytics, sensors and automation to drive cost efficiencies. We saw in the Deloitte video there of the lady who obviously has allergies and gets her antihistamine because obviously the data is integrated against the weather report. We know there's a high pollen count on Friday and she gets her antihistamine 2 days before. Whereas if she didn't realize what was causing her to sneeze all day, that's a GP visit. And I think we just prevent that hypothetically in that video. These functions can also be digitally improved by using enterprise resource planning solutions to make them shorter, faster, and more responsive. One of our cases with one of our clients in the past was identified that they were trying to get more surgeries out of a given day. And one of the things that they realized, starting to collect data by using timers. So they would time the knife start time, the anesthetic start time, the end time, the cleaning time. And what they realized is they would spend on average 25 to 45 minutes cleaning an OR because there was one person cleaning that OR. Now what they did is they doubled down on staffing when it came to cleaning the OR, and they were able to reduce that to 12 minutes, which meant they could do one more surgery every day, which meant waiting lists would go down, which meant more revenue for the hospital. But not having this data at your fingertips is a problem. If you don't know the problem exists, you can't tackle it. The ability to optimize without adding additional beds or staff, that is just the case that I just highlighted. We could get the Chinese over here and they could do their magic and build a hospital in 2 weeks. Would we have the staff to fill it? I don't think so. AI-assisted triage will also help us treat more patients without having to admit all who are seen or even on-site consultations. This is going to be key to how we drive healthcare in the future. It's going to be redefined care delivery, emerging features including centralized digital centers to enable decision-making, continuous clinical monitoring, targeted treatments, and the use of smaller portable devices will help characterize hospitals. These are the hospitals of the future, but I think they're needed now. You're going to end up with a digital patient experience. Digital and artificial intelligence technologies can help enable on-demand interaction and seamless processes through a choice of devices to improve patient experience. Taking away the fact that a patient has to come to your clinic and fill out paper forms and being able to fill that out at home, giving the patient access to their own patient medical record through internet connection will be very important in the future. And most importantly, when it comes to healthcare, is we heard the Minister this morning talking about the level of funding that's being spent on healthcare, and it's a topic that ranges globally, I'd say, in how efficient is the healthcare systems, and different countries will tell you we've the best healthcare system in the world, and the money they spend on it is huge. It's a huge tax burden. So most importantly, cost efficiencies and increased ability to deliver value-based care to a larger audience will place private hospitals at the heart of the community if they invest in big data. It's going to be key to getting us across the line. So I guess that concludes my, my presentation on big data. Happy to take some questions, and feel free to contact us. Our details are there online. Thank you very much, Emma. I'll hand it back to you.
Yeah, I might ask you to join us on the panel here. That'd be great. Thanks so much. So we've gotten through a lot there in that session, I think, and we're going to be going away certainly with some key takeaways. If I might just start with you, Harry, you referenced it a little bit earlier in your talk about what employers might be able to do to practically assist their workforce. And you spoke a little bit about empathy and introducing that into the workplace, and certainly I would concur with that. Are there any other practical tips that you would put forward for employers as to how to assist their staff with mental health and well-being in the workplace?
Yeah, I think obviously empathy is really important, because information, firstly, I think every employee should know what are the symptoms and signs of the particular conditions, and what are the very simple treatments that are available out there. I think there has to be an empathy, a sense of, do I really know what everybody working under me is suffering from? What are they struggling with? What difficulties are? In other words, I should be much more clued in at a personal level. You know, I know you have the large group, but I've always believed that the efficiency of a large group depends on the individual. And if you miss that point, you've missed the whole thing. Do you know what I mean? So it doesn't matter how efficient you are, unless you're looking after the people you care about. Obviously, I think there are big issues to be resolved here about what I would call work-life balance, and the amount of time in which people feel they have to be 24 hours available now. It's almost as if they feel they have to get up in the middle of the night at this stage to answer emails. So I think we have to have clear policies on things like emails. Like I keep saying to everybody, if we could only work from home exactly the same way as we work from if we were in the office, for example, and the same rule should apply. I start at a certain point, I take a break at a certain point, I finish at a certain point, I do not work after a certain time, I do not bring my work home. Because all of those things are really key, because we end up with a person out of work because they're about a depression or because they're totally stressed, and that has huge impact. And of course there's a lot of people working with depression in workplaces because of shame, because of they're struggling with their cognition, and so we need to become a lot more aware of that, because I think the cost of that is enormous to employ. So it's really well worth your while, I would say, as a group, to really invest in the mental health of your people. So I think making sure that you have clear rules and guidelines and that, trying to make sure that all your employees understand the importance of lifestyle and sleep and like I hate to say this, but in my experience, mental health in many workplaces is like a tick box exercise. It's like, okay, we've done that now. We brought in somebody to explain about that. But actually, have you really got down to brass tactics of what is mental health really all about? And I think some of those exercises, like in teaching people how to cope with uncertainty, teaching people how to cope with frustration, identifying these in your workplace, having discussions. To me, the most powerful example of this that I saw was where there was a particular organization, and I was so impressed by them, where the top person, the senior manager or the CEO, etc., would come into a group and he'd take off his CEO hat and he would say, today I'm John Smith. I'm a father, I'm a husband, I'm struggling, I'm stressed, I'm tired. And that allowed everybody in the group the freedom to open up and say, Jesus, I'm pissed off, I'm exhausted, I'm tired, I'm weary.
Yes,
and what it does is it brings mental health truly down to that level. And some people think that's weakness. I actually think that's great strength. That's people with vision who are bringing people with them. That's what empathy is really all about. It's bringing people with you, not telling them what to do, but bringing them with you. And that to me is really the key.
So modelling that behaviour is going to be key at senior levels in an organisation.
Yes, it has to start at the top, not at the bottom, but at the top.
And really, when you're talking about putting those parameters when people are working from home, I guess for a lot of us in hospitals, we have been in, so we haven't been working from home.
Yes.
But certainly for those working from home, that it is okay that you clock off at whatever time you normally clock off.
And I think identifying if you are in hospital and you have frontline staff, that you allow them the facility to say, look, I need time off here. I'm gone, I'm burnt. And giving them that and having that rotation and things like that. Now, it's terribly difficult at the moment because of circumstances, but that's how you look after the mental health. And if you notice there was nothing major there. It was all common sense. It was very simple stuff. But, I was just smiling there at the difference between big data and the simplicity of ordinary life. Do you know what I mean? Somehow we have to match these things together in a future going forward.
Yeah.
Because if we miss the individual and the single person, we've lost the whole thing.
Yeah. I think the bit that's congruent with your presentation was that it was quite person-centred in terms of the two. I suppose the Deloitte video really stuck in my mind in relation to the two individuals in their household, both with different needs. One which I was delighted to see with a mental health need was been flagged, but it is about that simplicity piece for the person. But how do you get technology to help that?
And remember, let's go to real life. Let's go to the heart of the country. They don't even have broadband.
Not where I live either.
So it's like as if there is this wonderful idea of how things could be. But there's a great line, you know, we have to take people where we find them, not where we'd like them to be.
Yeah.
And that's the key to mental health, really. We have to understand, where are people at? There's no point in having these wonderful ideas as to where we would love people to be. It would be wonderful like that, but we're back to the LFT thing. Do you know what I mean? You know, things are not going to change simply because I'd like them to change. It's what are we going to do personally, individually, in our lives, in our work situation, our families, and that's what's really going to make
Great, thank you. Thank you. And Fiona, you were talking about that digital poverty in your presentation, but I would like to talk to us a little bit more about the e-mental health initiatives that Mental Health Reform have been spearheading, and also the experience of your members in moving to that digital space that Ahmed was really referencing. So just what your experiences have been in that regard.
Yeah, so as Mental Health Reform, we've actually been part of an EU Interreg funded project since 2016. So from 2016 to 2020, we were working with our members, with the HSE, to try and look at digital solutions to perhaps to mental health, or providing mental health services. And you know, there was an appetite there, but it was low level. You know, there was a lot of apprehension. And then of course COVID happened, and you know, overnight organizations found themselves grappling with, what platform do I use? You know, will I use Zoom? Will I go for X? Will I go for Y? And I think that's what the Brave New Connections project tried to capture. And there's a lot more in the actual report, but a lot of our members, you know, are still, like, a lot of them did really innovative stuff, but a lot of them are still kind of looking at, what does it look like what does this future model of care look like? Because it's expensive, as you know, to change your model of care, to upscale in terms of the IT infrastructure, and then looking at the whole kind of group that isn't engaging. Like, some of the data that's coming out, like, you automatically make assumptions that young people love being online. They want to engage digitally. We've seen some preliminary data. Young people actually have no preference for online. They would rather do kind of, if they're engaging in counselling, other forms of therapy, do it in person. And I think there's some misconceptions out there. And then, you know, some other data that's coming out in some surveys that we've been doing, like, there's a kind of another misconception around, when you are engaging in e-mental health initiatives at times, you need a safe space to engage. So we've seen people, you know, perhaps women who are survivors of domestic abuse, or who are cohabiting perhaps with someone, they have to go out to their car, then they have to spend their money. So it's not a quick solution, but we need to do a lot of thinking about it. We need to look at the regulatory framework. There's safeguarding issues, there's GDPR issues, but as Mental Health Reform is part of that project, for example, we've engaged an independent consultant to do a market analysis of all the different platforms that are out there, because that's what our members wanted. They were like, which one should we choose? What do we know? So that's going to be done from now into next year, and we hope it'll provide some guidance on that. But we're linked in, because of the project, we're linked in with the Netherlands, Germany, France, the UK, pre-Brexit. We're also our partners. So we are quite behind, I think,
in Ireland.
Ireland, like, we haven't embraced it. We have huge broadband issues, you know, huge IT issues. And, you know, I think just a broader point maybe around data that I would make, like, in mental health, we do not know as a country how many people in this country are accessing mental health services. It was in Vision for Change to build a database. If we don't know what the needs are, how can we service those needs? You know, it's a basic premise, and, you know, it's wonderful to see you know, where we can get to, but it needs an injection of investment. And then when we spoke about, you know, the interlinkages between physical and mental health, like how many people accessing our mental health services are also, you know, in hospital for other types of
Cardiology
care.
or oncology.
Yeah, and we know that people, like, for example, people living with schizophrenia, the medication has side effects. They're more likely, if not controlled, to perhaps die of heart disease or high blood pressure. You know, that group of individuals need support in terms of access to dietitian, of physical health monitoring. You know, it's all interlinked, but if we don't have the data, if we don't know our individuals, we can't offer a person-centered approach. So, yeah.
And Ahmed, I think I was chatting to you earlier on, and it's interesting Fiona has brought up the question. It really seems to me that we should be investing in digitised healthcare, but actually as a collaborative approach between private and public healthcare, because as you've said, we don't even know how many people are accessing mental health services in the country. So surely we should have that kind of approach. And have you any experience of that happening in other countries, or where does it work well?
Well, yes, I mean, there's public records available that have interoperable data that you must upload medical messages, and then these files are all available for you to view, and that is important. It gives you a better synopsis of what the person is going through. It's also important, I think, to have that public-private synergy and availability to treat the patient in the best possible location. And the only way to know that is by having all the digital information available at hand of what the full picture is with the patient, because sometimes they don't know.
Yeah.
And using, whether it's a real-time doctor reviewing it or using artificial intelligence to direct that person to the best source of care at that time to treat that person. It's never always going to be a case of, yes, videos and digitization, but we're going to have the flexibility to bring people in if we need to, and better assess who needs to be brought in. As regards now, we just wait for people to turn up at A&E.
Yeah.
If we can assess who we should bring in and who should stay out of the hospital and be treated, if we have that flexibility in a time like a pandemic, it would be of great advantage to us. And if we can, in times of non-pandemic, which are hopefully coming soon, then ease those flexibilities back to bringing people in and having more one-on-one meetings, then that would be great too.
Yeah.
But having that flexibility and being a resilient healthcare system can only happen by having real-time data available.
And technology is really, it's way ahead of us.
It's way ahead of us, yeah, it's way ahead of us.
And I think the scary thing that I'm taking away this morning is that we're very behind as a country, and how as we spoke earlier and we heard from Oisin about it maybe taking 15 plus years for Sláinte care. We don't know with sharing the vision, but in terms of actually being able to grasp that whole requirement to get up to speed with technology, have you any views as to is it doable in the short term, or is it a long-term issue?
I think from the get-go, you need to assess the systems that you have in place, what the shortfalls are, and how you're going to move quickly to replace them.
Yeah.
And you need to replace them with a long-term view of how you're going to maintain them, offset part of your budget for them. I know we've had the whole cybersecurity issue recently, and a lot of questions that I get asked the whole time, well, what about cybersecurity? What about getting hacked? And what I can tell you is it's a war. It's a constant evolving situation. They find better ways to get into systems, so you need to offset investment as well as to how to keep them out. We're going to get to a stage where your password is going to be obsolete, and it's going to be your fingerprint that gets you into most of these records. So we make it more difficult, they'll find ways, and it's a constant thing. So I think going forward, how do we get there? It's one step at a time.
Yeah.
Get your digital hospital electronic medical record digital database in place, then start integrating against Healthline and the e-prescriptions, and then we suddenly have a full patient file and we know what medication they're taking. Suddenly we can identify population trends of what medication are we spending a lot on. Okay, we see a lot of antidepressants being written, we have a mental health problem, let's address that. Suddenly the spending on healthcare becomes more efficient. So my initial advice is to get your private hospital with a digital database from start to finish, fully comprehensive, collecting as much data as possible, until we know what the problems are, we can't address them. One of the biggest fears with COVID was we didn't know what it was. So we had to start collecting data in order to tackle it. And that's the only way we're going to get ahead of it, I think. So I think the initial get-go is to encourage people to change and start focusing on collecting data whilst delivering patient care.
So it is doable, and I think the wins are great in terms of what you explained there, in terms of we're not able to build a hospital in 5 years and staff it immediately, but certainly you can make efficiencies by using technology to allow more operations, or allow more virtual consultations.
Technology is there, it can be deployed in the morning. It's ready to go, so it's just a matter of pushing the button and making that effort, and it's definitely doable. Other countries have done it. They have patient portals with find available time features with artificial intelligence that actually can identify the quickest slot to treat the patient. So there's a lot of advantages there. Reducing waiting lists. It's all ready to go. What we don't have ready to go is more beds and more staff.
Yeah. Did you want to come in there, Harry?
I was just listening with great interest. Like, to me, one of the most vital things that needs to happen in this country is forget public and private. Every individual in this country needs to have literally the equivalent of a digital card or whatever you want, that literally all information, including their mental health information, their physical health information, is on that card. There are some countries, believe it or not, that when you walk into a hospital, it will already beep the person upstairs that you're coming in. It already will pull out your files, you know what I mean? So in other words, they're so far ahead of it. But like, how can we possibly get all this data if we don't start with the basics? There's no point in the private hospital collecting all this information, by the way. It has to be a national decision. And that's, I have to say, if there's one thing that I would go away in tears with after 40 years as a GP, and I think I can speak with a lot of authority because I've seen a lot of changes, is why in God's name can we not all sit down together and actually work collaboratively together to solve what should be a solvable problem? But if we keep going on in salvos and in different groups, and we have to stop this. I mean, Sláintecare is an attempt to stop it. At the speed at which Sláintecare is going, I cannot see Sláintecare within the next 10 years, unless there is serious investment and unless there is a decision about everybody to get around the table and stop saying, there's almost these decisions of, I'm going to take that approach and I'm going to take that approach. We need to sit down as a mature population and start one. How are we going to look after the physical and mental health of our people? My God, we've 5 million people. Surely to God, we should be able to do it. And I keep coming back to this thing of prevention. Like, if we can get a lot of these skills in there, we won't have all these people looking for CAMHS things because the kids will know what to do. Do you know what I mean? So, and I loved the idea of the virtual thing, and this assessment of the virtual. I think this is really important. I think it's a very interesting thing in general practice, that general practice GPs are now realizing, yes, we can use a blended form very well. So if we could learn to use technology sensibly and properly, it would be very helpful. The one provision that I've said to all GPs, the one thing you must have in a virtual confrontation that's to do with mental health, you must be able to see the person.
Yes. Yeah.
And that to me would be a key event. But I think there's so much, there's so much knowledge here, there's so much wisdom. All it takes is for everybody to get down and start working together. I know perhaps it's a Cinderella approach to believe that human beings could actually work together. But, we in Ireland showed in COVID, we are well able to get off and work together as a community, as a people. Our people are crying out for this. You can see from the surveys there from Motion this morning, people are crying out for sensible solutions. And I believe in this country, we need to get together, sit down, stop. We have a great line in therapy, and I'll finish with this statement. If we spend all our time looking at the problem, all we're going to see are the problems. If we spend all our time looking at solutions, we're suddenly going to start seeing solutions. And maybe that's the approach that we need.
Absolutely. And I do think if we'd been sitting here this time last year, we mightn't have been so hopeful. I certainly am going away today with quite a bit of hope, because we started off this morning hearing the Minister firmly talk about private and public coming together for a health system. I think we need mental health and physical health to come together. We have technology now that's there to help us and enable us to have this whole system-wide approach. So I think certainly the future is bright. We have the will to do it. Let's get on with it, is what I'd say in relation to that. So I think unless we have any more questions, I think we've had 3 really important presentations this morning, all with areas that we need to really focus on in the next while, both from the personal, the individual point of view to the whole systemic system that we have. It's been a wonderful conference here this morning. We've had a great lineup, and thank you, Bill, for your original chairing of the first session and for taking on the mantle of the chair of the Private Hospitals Association. And thanks to David and your team for all your work, and to Irla for getting us here today and making sure that everything ran smoothly. It is quite different having a hybrid approach and being both virtual and physical. So thank you all, and we'll conclude with that. Thanks a million.